Good morning to all the virtual participants. I, Saurabh Kose, on behalf of ISF College of Pharmacy, welcome you all virtual participants on the occasion of World Hypertension Day. I welcome our today's guest, Dr. Ajit J. Singh ji. Sir is the cardiology from Manipal Institute of Medical Sciences, MAHE, which is a prestigious medical institution. I also welcome our today's chief guest of this session, Professor Dr. R.K. Naran sir and Dr. G.D. Gupta sir, the chair of this session. As you know that hypertension or high blood pressure is one of the topmost 10 diseases of the world, which is also called as silent killer. So today's session is more specific about the awareness campaigning of the hypertension. So without taking much time, first of all, I would like to invite Professor G.D. Gupta sir to give his welcome remarks about this today's awareness campaigning. Over to you, sir.
So, good morning, everyone. And this is my foremost duty to welcome today's speaker, Dr. Ajit Singh ji. And he is a very dynamic and involved in a number of professional activity related to the healthcare system and associated with the climate. And I feel that this is the fourth or fifth meeting only in the virtual platform. And I come to know that he is the organized number of the national and international level of the seminar, conferences, workshop, and all these are the very helpful to the student. As we know that during this pandemic situation, it is very difficult to run any show in a systematic order. So only the platform is the virtual, and he invite number of the renowned speaker, and I was also is on the platform, and I have also come to know how which types of the activity is going on in the pharmacy practice and how we can develop or grow our profession as well as our the future. So welcome you, Dr. Ajit ji, and I also welcome Dr. R.K. Narangi, Vice Principal and Controller of Examination, ISF College of Pharmacy, and he is the one of the pillar of this institute, and their dedication toward the profession always give the strength of the student. He is also vice president of the SPR. So number of the activities they are the organizing, including one of the most important part is the IIC. This is the Institutional Innovation Council. So this institute is also doing some of the most appropriate activity which are related to the students. And moderator of today's webinar, Professor Saurabh Kose, so very well known in the field of the pharma profession, and he is very dedicated toward the pharmacy practice and always involve the scientific, technical, and the social activity which are required for the society. As you know that in those days the topic, or we can say we are the going to the celebrate or giving the just like information of the world hypertension day we are the going to celebrate. So I know that how many situation is the creating due to the hypertension. So as you know what is the need of the hypertension, what is the utility of the hypertension, as we know that from the bottom to the top head, so how the blood is the moving toward the body, so we can say this is the requirement of the pressure inside of the arteries and vein, because without this pressure we cannot survive. But when it can be over to the limit, then how it can be create the difficult situation. So not only the only a particular type, you can say the blood pressure or hypertension like that, it can be create number of the problem in the other organ, including the heart, kidney, and almost probably including our memory function, brain, eyesight, so many things. So as we know that during these days, our environmental condition, our habitual condition, our dietary conditions, they all are changed. And what I feel that one of the component, or you can say chemical, which is very important and essential to our body, this is known as the sodium. and sodium potassium ATPase pump. We require these types of the substance for the body, and for the completion of this one we are the using the salt, and it have the sodium chloride obviously, and number of the product available in the market. But due to the age condition or due to the taste buds, so God has given one of the special sense. This is known as the taste. Sure, making the taste, we are the using the concentration of the, you can say, salt at a higher part. Let us consider chips, and you can say number of the candies, number of the achar, like that. They have the lot of quantity of the salt which are not required to the body. But because of the satisfaction of our taste buds, we are using this one. As doctor recommended, most probably the 5 to 10 gram in a day, whole day for the one person. But even in a one diet we are the using near about the 10 grams. So most probably we are taking 2 to 3 times of the salt in a day. That's my calculation, and I have developed one of the product. This is known as the Swadji, and the concept of this one के how we can satisfy. मैं एक हिंदी में आपको चीज बता देना चाहता हूँ, बड़ी इंटरेस्टिंग है. दिस इज द वन ऑफ द हाईली इंटरेस्टिंग. एक समय कैप्सिकम बहुत ज्यादा कॉस्टली हो गई थी. इट इज द वेरी हाई कॉस्टली. दिस इज द इवेंट ऑफ माय विलेज. और एक पंडित जी थे, उनके यहाँ 10 बैलगाड़ी, मतलब उनके यहाँ 10 जो थे वो काम करने वाले थे, जो हल को हाँकते थे या बैलों को ले जाते थे. उनका कंजम्पशन एक दिन का रेड कैंप्स जो चिली है, दिस इज नियर अबाउट द 100 ग्राम और मोर देन दिस. क्योंकि इतना ज्यादा वो खाते थे और वो बहुत ज्यादा कॉस्टली थी. तो मैंने एक दिन ऐसे ही, उन्होंने बताया कि व्हाट इज द टेस्ट. टेस्ट कहाँ से? टेस्ट अप टू द टंग. टंग के बाद तो पता ही नहीं है कि कैप्सिकम खाई या नहीं खाई. तो हमने कहा फिर आप क्या करते हैं? तो आपको ये हंसी आएगी सुन के. वो कहते थे हम खाना खाने के लिए उनको बिठा देते हैं और कैप्सिकम में कट लगाते हैं और कहते हैं टंग निकालो, और उनकी टंग पर रगड़ देते हैं. और बोले उनका खाना पूरा हो जाता था. ओनली ऑफ दी 1 ग्राम भी एनफ थी, समझ लीजिए, ऑन ऑल 10. और जब दूसरे को खिलाना, थोड़ा फिर कट लगाया, उसको घिस दिया. देखिए उस दिन मुझे मजाक लगा था, लेकिन इफ यू कैन कैलकुलेट द ओवरऑल, कि वो व्यक्ति की इंटेस्टाइन के लिए औषधि का काम कर रहे थे, जो रोज जहर की तरह खा रहे थे. सो दिस इज वेरी वेरी इंपॉर्टेंट, कि बिकॉज द सेटिस्फैक्शन ऑफ अवर टेस्ट बर्ड्स, how many things we are the eating without any calculation, without any knowing that what happened inside of our in the organ. तो आज मुझे वो बात याद आ रही है कि हाउ इट इज द यूजफुल. तो मुझे ये लगता है कि जो पुराने लोग थे वो साइंटिफिकली छोड़ दीजिए, बट जो टेक्निकली थे, जो अंदर से थे, जो उनका आयुर्वेदा था, या जो उनके कंसेप्ट थे, दिस इज वेरी वेरी इंपॉर्टेंट. उन्हीं की एक बात आपको बता दें कि ये चीजें कितनी इंपॉर्टेंट. फर्स्ट टाइम ही हैज कम टू नो दैट, कि साइकिल का पंचर था, मैं साइकिल को ले जा रहा था, बहुत छोटा था. बोले क्या हो गया? हमने साइकिल का पंचर है, और पंचर वाला एक ही गांव में था, वो है नहीं. बोले इधर आओ. मैं गया, उन्होंने लाल मिर्च को तोड़ा, उसके सीड निकाले, और उसके अंदर जो लगी रहता है, जो पॉइंट वाल्व लगा रहता है, उसको खोल के 15-20 सीड डाल दिए. उसको डाल के बोले हवा भरो, और तुम जहां तक जा रहे हो चले जाओगे, हवा नहीं निकलेगी. So these types of radiotherapy in the cancer system, what we are the using, some of the puncture of the intestine, how we can find out like that. उस समय they are knowing that. So I know that Dr. Ajit Singh, he is a very very dynamic. This is only the basic about what we are the talking today. So I hope that we can consider, he will consider all the technical parameter which are related to the anatomy and physiology, and how we can control what happened if the hypertension is the increase. And I hope that what types of the condition they will consider during the lecture, one of the environmental condition, habit, as well as how we can control with the medicine or the treatment. Because after all, if any it converted in the form of the disease, we can't control with the yoga, or you can say environmental condition like that. For this purpose we need obviously some of the medicaments, some of the treatment with the help of the after the physician consultant, like that. So thank you very much. I hope that all the participants you can interact, and if you have any question you can send through the our WhatsApp group, our WhatsApp, as given by the Saurabh Koseji through the, you can also give the your question on YouTube channel, so we can consider accordingly, even during the discussion or a speech or after that, because time is the very short, and I know that he is also very busy personality. Even that nowadays it is very difficult, you can the hold the online platform for the 1 hours and 2 hours like that. So again, welcome whole of the panel. So thank you very much for provide this opportunity, so I can say that this is not a celebration, this is the social information, and this is the our moral duty being a pharmacist, to give the awareness to our all the society peoples, those are connect with this one, or after this lecture it will be the available on our YouTube channel, so we can come together and you can know some of the very very important information related to the hypertension. Thank you very much.
Thank you, sir.
Thank you, sir, for your words of wisdom, encouragement, and the holistic concept to treat the disease in our ancient time.
Yes.
So now I would like to call Professor R.K. Narayan sir for a couple of words of blessings for today's gathering. Over to you.
Good morning. Teachers, today is the World Hypertension Day. Actually, it should be named as Hypertension Awareness Day, because there is no need of awareness regarding that. As suppose that hypertension, when tension increase its limit, what are the hypertension? आज की डेट में सबसे ज्यादा दिक्कत कहाँ से है?
अजीत जी आप एक बार अनम्यूट करें प्लीज, म्यूट कर लीजिए थोड़ा। यार
हेलो, am I audible sir?
ओके डॉक्टर साहब, यस यस यस।
आज की डेट में देयर आर लिमिट्स इन एवरीथिंग, चाहे हमारा इंटेक फूड की लिमिट है, चाहे किसी डिजीज में किसी भी पैरामीटर की लिमिट है, लेकिन अपनी गलत हैबिट क्या है? फॉर ईटिंग वी ऑलवेज यूज अपर लिमिट। जब भी कोई डिजीज की बात आती है, हम जो लोअर लिमिट को भी टच करें तो हम एकदम से टेंशन में आते हैं, पता नहीं क्या होगा। तो अवेयरनेस जो है ये ज़्यादा जरूरी है रिगार्डिंग द लिमिट, रिगार्डिंग द टेंशन एंड द hypertension. So today's theme is to measure your blood pressure accurately, control it and live it. So our teacher, Dr. Ajit Singh, will tell about the effects, about the side effects, about the treatment, how to treat these type of hypertensive tumors. So I'm not taking much time and will not be much more within the speaker and our audience. So over to Saurabh Koseji to start the lecture.
Thank you so much, sir. Now, without taking much time, it's time to introduce our today's speaker. So let me have the introduction of our today's speaker, sir, Dr. Ajit J. Singh ji. And within very short duration, I will start, sir. So Dr. Ajit Singh is a co-founder and chief executive officer at Claymate Research Solution India, and he is also a young entrepreneur and scientist. He has completed his PhD from in cardiology from the prestigious and eminent Manipal Academy of Higher Education, Mahe, a leading organization in research and education in India. Recently, he has been appointed as Research Associated Grade 3 for ICMR at Department of Medicine, KMC, Manipal. He is also serving as National Director for Research at World Youth Heart Federation and Principal Investigator for Manipal Heart Failure Registry, MHFR. He has published more than 40 papers in different streams of medicines, including cardiology, cardio-oncology, infectious diseases. He is the investigator and site coordinator for many international clinical trials. Dr. Singh serves as an honorary reviewer in many reputed journals, including Oxford Group, BMG Group, Springer Group of Journals. Dr. Singh has been appointed as Editor-in-Chief, Journal of Basic and Clinical Cardiovascular Research. is also an editorial board member for several medical journals. He has received several international research and travel grants from esteemed organizations, including the European Society of Cardiology, Indian Council for Medical Research, DST SAB, and American College of Cardiology. He received the Young Achiever Award 2019 and Young Scientist Award 2020 in cardiology research from reputed international organizations. Dr. Singh has traveled more than 10 countries in regards to his research, presentations, and invited law. So, without taking much time, I would like to call Professor Ajit J. Singh for his talk on the World Hypertension Day today's theme lecture. Thank you so much, sir. Mike, Ajit ji, yeah.
Yes, yes. Yeah. So thank you for the nice introduction, sir. And thank you for the invitation. You have invited me. Of course, it was a short notice, but I'm glad that, to deliver this talk for the student of, ISF College of Pharmacy, Moga. And, people can watch on YouTube channel, even other people can watch. Thank you, Gupta, sir, for inviting me. And yes, this is our fifth or sixth meeting virtually very soon. I hope everything will come down and we'll see you personally. We'll visit Moga. And thank you very much, Narang sir, for the kind words. So, yes, without wasting time, uh, today is World Hypertension Day, as we know. And this is, I think, one of the most common cardiovascular problem. Why we consider it cardiovascular problem? Because this is the problem which is originated from the peripheral resistance or from the arterial origination, right? And this is one of the most common risk factor for cardiovascular problems, right? And in that, in today's talk, I would like to go through very basics for our students. In that basics, I will cover about the BP checking, what are the recent updates in BP, and what are the guidelines which has come recently, and what they say about the treatment, about the lifestyle modifications, and what are the drugs commonly used for the hypertension treatment, right? So I will share my screen, sir. Yeah, one sec. Okay. Yes. Okay. Is it visible, sir?
It is started. Just a minute.
Okay. So I hope it is visible. Yes. So today is our World Hypertension Day. The whole world is celebrating World Hypertension Day. So this is our moral and ethical duty, and being into the profession, we should aware our students. We should aware the public about the basics of.
अजीत जी इसको पूरा फुल स्क्रीन कर लें क्या?
सर फुल स्क्रीन कर दिया मैंने.
ओके ओके ठीक है. ओके
आया क्या फुल स्क्रीन सर?
मुझे नहीं दिख रहा है. कोसे जी ओके?
इधर विजिबल नहीं हो रहा है. अजीत सर, व्हाट यू कैन डू इज
ओके, वन सेकंड. ओके, one second. I'll share again.
ये स्लाइड शो कर दें. हाँ, अगेन यस प्लीज.
Yes, 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 sir. Definitely. Now, sir. Hello, Kose, sir.
Yes, sir. Now it is visible.
Now it is full screen?
Yes, sir.
Okay, great. So, As we are celebrating today the World Hypertension Day, this is our moral and ethical duty being into the profession to aware our students and to aware our general public about the hypertension, and they should know what are the consequences they can get if they are having the high blood pressure, right? And what are the basic treatments, what are the lifestyle modifications in the initial phase of hypertension they can take care, and they can treat themselves. So today, without any delay, I'll just start with my conflict of interest. So there is no conflict of interest because this presentation is made only for the educational purposes. And I have referred few scientific papers, few guidelines, and few website material to prepare this presentation. So hypertension is nothing but it is persistent elevation in your arterial blood pressure. Arterial blood pressure means your blood circulation has some level of pressure to flow, because without pressure it won't flow. If you check out your a water system or water supply in your house, there is a need of pressure to flow that water into the pipes, right, into the pipe. So there is the same system in our body. There is a certain level of pressure which is needed to supply our blood to our organs from the heart, right? So heart is our machine, heart is our engine to supply the blood to the whole body, to the different parts, and it is having some certain levels for to supply the blood, right, to supply the blood, and including nutrients, and there are many other particles from the from the digestive system, from the gut, which are going to the whole body for the nutritional purpose. And like we are giving some drugs, so drugs has to be reached to a targeted organ. So these things are going through the blood. So we need some pressure to flow that blood throughout the body. So if that pressure goes above the certain level, right, above the certain level, if it goes, then that condition is called hypertension, right? And there are the Joint Committee National on Detection, Elevation, Evaluation and Treatment of High Blood Pressure, that is called Jnc Guidelines. So these Jnc Guidelines are the topmost guidelines or topmost committee, we can say, in the world, which decides like what are the levels of blood pressure should be there. And they only make the proper guidelines or proper information they give about the hypertension, and they do a lot of studies, and based on the studies, evidence based studies, they come up with some levels, they come up with some the medications which are in the trend and which are actually benefiting the patients. So they develop certain information for the healthcare professionals, for the students to learn that this is the latest update, and that's how we have to define the hypertension, that's how we have to treat the hypertension, right? So there are two types of hypertension basically. One is primary hypertension, and one is secondary hypertension. So primary is also called as essential hypertension, and that essential hypertension is a clinical syndrome which has compiled with many other many other informations, or many other symptoms, or many things, but we do not have the certain cause for the primary hypertension. We do not know the reason of primary hypertension. That is the only thing which distinguishes essential or primary hypertension or idiopathic hypertension from the secondary, because secondary has some cause. Secondary hypertension is caused by some comorbidities, some drugs, some toxic elements in the body. But primary or essential hypertension or idiopathic hypertension, there is no cause, right? We don't know the etiology. Etiology is hidden, or etiology is not properly defined. So right now, if we look at the if we look at the statistics, there are more than 1 billion individuals worldwide who have the hypertension. And very interesting fact, currently we got actually one new guidelines from Europeans, from the Europeans, and from American College of Cardiology and American Heart Association, AHA and ACC. So they have come up with the new guidelines, and suddenly by these guidelines, almost 1 billion people, oh sorry, 10 million people, suddenly 10 million people has come to the hypertensive group, who were healthy before these guidelines. They were perfectly healthy before these guidelines, and suddenly these guidelines has come and they have defined the hypertension again, and they have decided the cutoff value for hypertension again, and suddenly 10 million people who were perfectly normal and perfectly healthy has come up into the hypertensive group. Either they need medications, either they need lifestyle modifications, but now they are hypertensive actually. I mean, there are certain there are different regions which are coming out, like these guidelines have come up with the new evidences, but these, or some are telling, some are criticizing those things, like it is decided by the pharma industries, or this is decided by the drug makers, because they want to sell their products much more. But of course, when these guidelines say something, people have to accept. Our medical fraternity have to accept that, and they have to believe that, okay, this is the actual scenario which is going around the world, right? And what they have decided, they have decided the blood pressure cutoffs, which were less than 130 to be normal before, less than 130 mmHg by 80 mmHg. Now they have reduced that to 120. So now only normal blood pressure will be counted, which is less than 120 by 80 mmHg. More than 120 to 130 would be counted in your hypertension, or pre-hypertension, we can say. So this is again a stressful situation for all of all of the people who have their blood pressures in the range of 120 to 130, because suddenly they are feeling like they're hypertensive. They become hypertensive without any reason, without any other comorbidity, or without any other problems. Now they are hypertensive, and they have to visit doctor, they have to take medications, or they have to go for lifestyle modifications. So guidelines says that, but we have to believe, right? And now, as I was telling, 90 as I was telling about the types of hypertension, there are two types. One is essential, primary, or we call it idiopathic, and the next one is secondary hypertension. If we look at the ratio, our patients, or what we say, our population, 90% of hypertensive population is primary hypertension. Okay, 90% of our hypertensive population is having primary hypertension or essential hypertension, and then rest 10% is secondary hypertension. So as I was telling, the primary hypertension or essential hypertension does not have any pathophysiologic etiology. It is unknown to us. It cannot be cured, but it could be controlled by the drugs, right? The secondary hypertension is like there is a specific cause for a high blood pressure. There are specific comorbidities, or there are drugs, or there are toxic substances which was taken by the patient, or maybe stress, or maybe stressful reasons. So that could raise your blood pressure, right? And that could be treated. So in that treatment, we just have to treat the comorbidity, we just have to identify the cause, and we have to remove that offending agent, or we have to remove that offensive toxic substance. This is the first step of management in secondary hypertension. But the ratio of secondary hypertension is really less. So as we have 90% of primary hypertensions, we could go for the drugs, we could go for the drugs to control the hypertension. It cannot be cured, right? So there are certain disease and drugs which are associated with the secondary hypertension. Diseases are like, if the patient is having, or if someone is having chronic kidney disease, it could lead to hypertension. If someone is having coarctation of aorta, this is a cardiac problem. And obstructive sleep apnea, if they have the obstructive sleep disturbances, then it could lead to hypertension. Then our thyroid problems, and then aldosteronism, and then there are some other kidney problems like renovascular diseases or other thyroid problems. So these can lead to hypertension, right? And there are some drugs which again are associated with the hypertensions in human. And these drugs could be corticosteroids, estrogens, or erythropoietin, or any anti-cancer drugs like cyclosporine, tacrolimus. And there are some more abusive drugs like cocaine, or nicotine, or anabolic steroids. So these drugs also participate in raising your blood pressure. So we have to avoid these things. We have to should keep these things away until and unless we need these things medically. Okay, we need these things to treat some problems which we have. Otherwise, we should avoid, and we should not go to that, because it can raise your blood pressure and if it raise your blood pressure, you might need the medications to treat that blood pressure, or to calm down your blood pressure, right? And definitely, as Dr. Narang was saying and Dr. GD Gupta sir was saying about the sodium, because the food substances which has the high sodium levels could raise your blood pressure. Because in pathophysiology we'll see sodium is directly or we can say direct proportional to it is raising the peripheral arterial pressure, and it is even increasing the peripheral resistance, which is directly associated with your hypertension or raising your blood pressure, right? And of course your smoking, nicotine, and then ethanol, alcohol consumption could raise your blood pressure, definitely, right? And then some food which can which contains tyramine or licorice, those things could raise your blood pressure as well, right? And if you accidentally consume some chemical elements like lead, mercury, thallium, and other heavy metals like lithium, it can also raise your blood pressure. So be aware of these things, and if you are aware from the starting, you can control the hypertension, you can control the blood pressure as well, right? So these are some terms what we should know actually. Arterial blood pressure, what is arterial blood pressure, and what is, we when we go for the blood pressure checking, you always know that blood pressure is always in two digits. Two digit means systolic blood pressure and diastolic blood pressure, right? So systolic blood pressure is something which has come at the cardiac contraction, and it represents the peak value, the highest value of your pressure, highest value of your arterial pressure, right? And diastolic value is something which has come after the contraction, when cardiac chambers are filling, and it represents the nadir value, it represents the lower value, lower side value, right? So that's how we consider systolic and diastolic pressure, blood pressure. And why we consider both, we don't consider only single one, because it is like before and after cardiac contraction, right? So we can consider one but not, because in some cases only systolic blood pressure is high. In some cases, if diastolic blood pressure is really high, then it could be considered as hypertension. In that case, maybe cardiac contraction is normal. Before cardiac contraction or during cardiac contraction, the things will be fine, right? And I'll tell you example. This could happen in case of coarctation of aorta and some other cardiovascular disease, or some other valvular heart disease, that your systolic blood pressure is normal, but your diastolic blood pressure could be really high. So we have to go for two values, not the single value, right? And arterial blood pressure, I was telling, this is the measured pressure in your arteries, which is also considered as millimeters of the mercury, right? mmHg, right? After blood pressure, mmHg. So that is millimeters of the mercury. Hg is mercury's chemical name, right? So it is the interplay blood flow and resistance to the blood flow. How much resistance it is causing, how much pressure inside the arteries we are facing, our blood is facing, or our blood is flowing through, that is called blood pressure, or that is called arterial blood pressure, right? So it could be, if we calculate it, it is equal to cardiac output into total peripheral resistance, right? Your blood pressure is equal to cardiac output into TPR, total peripheral resistance, right? So it is simple to understand. We have to go for arterial blood pressure, that is counted by total peripheral resistance and cardiac output, and then systolic blood pressure, the highest peak during the contraction, and diastolic blood pressure after the contraction, lowest value, right? And then pulse pressure, because during the blood pressure we also check the pulses. So pulses is something, the difference between SBP and DBP, right? Difference between SBP and DBP is called pulse pressure. It indicates the arterial wall tension, right? How much, or how many times the arterial wall is pulsing, or is, showing the activity, is known as pulse pressure, right? And then mean arterial pressure. Mean arterial pressure is something, the average of pressure throughout the cardiac cycle. Average pressure throughout the cardiac cycle, whether it is before the contraction, during the contraction, and after the contraction. This is the average of all the pressures, all the pressures. If we get the mean, that is called mean arterial pressure, right? So mean arterial pressure can be calculated by this, because there are three values. One is before, during, and after. There are three values. So it can be calculated by 1 divided by 3, or SBP by 3 plus DBP into 2 by 3, right? Okay, so the current classification uh, from the ACC, AHA, and from the Jnc guidelines, current classification shows, as I was telling you, the less than 120 by 80 is normal. Okay, less than 120 by 80 is normal, but the people who are even having more than 120, or between 120 to 130 systolic blood pressure and 80 to 89 diastolic blood pressure, they are in the pre-hypertension category. They are under the consideration, under the monitoring, or under the lifestyle modifications. And if they are worried, they can go for medicines, right? Because we people have the stress much more than the disease, much more than any disease. We have the stress, and that stress is really really a very, very bad thing for our body, for our physiology, for our pathology, for our the whole body, or all the systems. Like, so in that case, we should be aware of that things, and we should not make us stressful. But to reduce the stress, people go to the doctors, people visit the clinicians, and people go for the medicines. But I will say here that the people who are in the young age, and who have the who are coming in the pre-hypertension category, they should not go for the medicines as soon as like they need. It is not necessary. They can try their lifestyle modifications hard, and then I'm very sure then they can definitely cover up their blood pressures. They can definitely calm down their blood pressures. And why I'm telling this, because if they go for go to avoid the alcohol consumptions, then they can go to avoid the smokings, and they can go for the sodium restrictions, and they can go for other drug abuse things. They can give up these things easily, and they can go for the brisk walk. They can go for the yoga. They can start exercising, right? So these things will definitely help, and these things are the primary thing which can cover your calm down your blood pressure, right? So this is pre-hypertension, 120 to 139 SBP, and 80 to 89 DBP. And stage 1 hypertension is 140 to 159 SBP, and 90 to 99 DBP. So these are just categories based on the blood pressure levels, based on the blood pressure values. And stage 2 hypertension, it is considered when your systolic blood pressure is more than 160, and your diastolic blood pressure is more than 100, right? So this is a normal blood pressure for the healthy person. But if you are diabetic, or if you have the chronic kidney disease, if you are diabetic, or if you have the chronic kidney disease, then your value of blood pressure will be considered from 130 by 80 mmHg. Your systolic blood pressure less than 130 would be counted normal, right? So these are the evidences, these are the guidelines of International Society of Hypertension, and they made the guidelines, and these guidelines has come in 2020 only, the last year June, okay, almost a year back. So these are the most used guidelines right now, because this has come from the Society of Hypertension. So now, again, one more difference I want to tell you. These categories, what I told in last slide was, from the evidences, and these were the considered as, normal categories. The students should know, right? Students should know these things. But being a professional, we should be aware of all kind of blood pressures, like what is office blood pressure, what is ambulatory blood pressure measurement, and what are the home blood pressure measurement. Why we are considered, and why they have divided office, ambulatory, and home blood pressure differently. Why? Because see, when the doctor, office means the doctor's office means the OPD. Office means when the patient, or when a particular individual have the stress, right? When you are visiting a doctor, your blood pressure will definitely raise to a certain level. Okay, your blood pressure will raise to a certain level. So that level of blood pressure, or your level of your stress at the office of doctor would be. Is any problem, sir? Any problem, Saurabh Kose, sir?
Maybe all well, sir. Please go ahead. Thank you.
Okay, thank you. Yeah. So office blood pressure is always considered at least 10 mmHg higher than the normal cutoff. Why it is considered to be, as I'm telling, this could be a stressful situation when any patient or any particular individual visit the doctor's office, because they have that in mind. I'm with the doctor, I'm in the hospital, and a lot of stress is there. Like, why I'm visiting doctor, do I have any problem really? So in that case, your stress will lead to raise your blood pressure at least 10 mmHg, right? So in that condition, the normal SBP and normal DBP is considered to be less than 140 and 90, right? So office BP, if you consider that your office BP should be less than 120 or less than 130 to be normal, nothing. It could be if it is less than 140 by 90, it could be considered. And like when you are really checking in case of a blood pressure patient, or in you are going for any particular individual with comorbidities, then less than 140 by 90 is also acceptable. And then ambulatory BP, why this ambulatory word has come? Because see, ambulatory BP is checked complete for 24 hours, right? Complete for 24 hours, and it counts your blood pressure every minute. Ambulatory blood pressure counts your blood pressure every minute, and it will give you the average. It will give you the average at different phases. Different phases. What does it mean? Like when you are walking, when you are sleeping, when you are awakened, when you are lying down, when you are sitting, when you are standing. So every phase your blood pressure will be counted, and you will get average of every phase, and you will get average of the whole 24 hours. And why it is needed? Because few people have postural hypertension. Few people have the raised blood pressure on certain positions, when they are lying down maybe, or when they are walking, so their blood pressure rises, right? Or when they are working out, or when they are exercising, their blood pressure rises. And normally when they're sleeping, their blood pressure is lower, at the lower side. So to check that difference, to check that discrepancy, we go for ambulatory blood pressure measurement. So 24-hour average should be less than 130/80, and daytime awaken less than 135 and 85, it's considered to be acceptable. And nighttime less than 120/70 is acceptable, right? To be normal in case of ambulatory BP when you are checking. And home BP, it is acceptable to be less than 135/85. So these guidelines, or these criteria of hypertension is actually based on the evidences, based on the big researches, big data, analytics. After they have come up with these things, like, okay, office BP could be this much, or home BP could be this much, or if you are going for the ambulatory BP for certain population or certain people, it could be this much. So these are the different things what we can consider to be normal, right? Now, how to check the blood pressure? That is very important, because the factors around while checking the BP are directly affecting your blood pressure, right? So there are certain positions, there are certain conditions, there are certain environmental fixations which can which actually are the instructions for any clinician, any pharmacist, for any nurses who are checking the BP. And what are those? Your room where you are checking the BP, it should be comfortable with temperature. It should be quiet. There should be no smoking, coffee, or exercise for last 30 minutes. So the patient or the particular individual, or anyone who is coming to check the BP, he should not have smoke, or he should not have the coffee for last 30 minutes, because caffeine can increase your blood pressure. And smoking, again, nicotine can raise your blood pressure. And the people must be empty bladder, and before coming to blood pressure, at least 3 to 5 minutes they should get relaxed. If someone is coming to your office directly by walking or by climbing stairs, if you're checking blood pressure at that time, it would be definitely raised. And it would not be raised only by 5 mmHg or 10 mmHg, it could be raised by 20 mmHg also, because in exercising, or during the workouts, your blood pressure increases really high, correct? Because of your adrenaline rush, and because of the happy hormones, it is it is always raising, right? So before checking the blood pressure, the individual should rest at least for 3 to 5 minutes, right? And for the actual BP measurement, you should take, whoever is checking the blood pressure, take at least three measurements at the interval of 1 minute. So within 3 minutes, check at least three blood pressures and then get the average. Then get the average, right? Okay, and the sitting positions for the patient or for the individual for whom you are checking the BP, it should be back supported, no talking during the measurements, and cough should be fit on the arm size. Whether usually we use small or medium sizes coughs, and arm should be bare and in the resting phase. Resting phase means it should be kept on something. It should be kept on the table. It should be kept on the armrest of the chair, but it should be in the rest press. It should be in the rest position, right? And BP should be checked or must be checked by the validated electronic upper arm cuff, or any maybe manual sphygmomanometer. We can check the blood pressure by that, but it should be validated. We cannot just go with the non-validated instruments, because they can influence your blood pressure, and they can give the incorrect readings to you, right? So these are some specific considerations or specific instructions while checking the BP. If you are really want to get the correct blood pressure, or so you should follow these things, right? So yeah, so now, what are the blood pressure checking plans for the long term for a healthy person, right? For the healthy person, or for the for anyone who is going for the annual checkup or going for some checkups. So what should be the plans? So when you are going to the doctor and doctor said, or you get your blood pressure is less than 130/85. Okay, when you get that your blood pressure is less than 130/85, that means you are considered to be normal, and you can check your blood pressure annually, right? You can check your blood pressure annually. No need to go for every day or every month or every 6 months. You can check your blood pressure in a year, just to assess the risk factors. And you can just try to assess the risk factor yourself. If you have started smoking, if you have if you quit the smoking, if you have started alcohol consumptions, if you quit the alcohol, if you have reduced your salt diets, if you have reduced your water consumptions. And yeah, I mean, there are the risk factors which you can assess, right? If you get the kidney problems, so these things can be assessed, and your blood pressure could be checked annually. If you are a healthy person and your blood pressure is less than 130/85, you can check it once in a year. No need to go daily to the doctor and check your blood pressure, right? Because it will not increase suddenly, because your blood pressure could need something. See, in sudden accidental cases like mercury consumptions or any toxic substance consumption, it will be raised immediately. But in normal conditions, when you are healthy and you are not having any risk factor, annual checkup is okay. Okay, but when you go to the doctor and your blood pressure is somewhere around 130 to 159, or 85 to 89 diastolic blood pressure, so just try to confirm out of office blood pressure. Why? Because when you are with the doctor, you are checking, it could be white coat hypertension, or it could be masked hypertension. Masked hypertension or white coat hypertension means you are with the doctor, your blood pressure can raise due to stress, because you are visiting doctor. That is, again, a stressful situation for a healthy person. So better go out of the office, go out of the hospital, go out of the OPD, check your blood pressure at home, or go for the ambulatory blood pressure. Okay, check the average of ambulatory blood pressure, and then again come up to the doctor. And if it is not coming down, if your blood pressure is same at home, also at your ambulatory blood pressure is also more than 130 and more than 85, then you should confirm it with the repeated measurements, right? And when your blood pressure is more than 160/100, that means you are hypertensive, and you need to recheck your blood pressure, or you need to go for the therapy or go for the lifestyle modification. Then it should be instructed by the doctor when you have to check. But usually we go for weekly blood pressures at home. And for the doctors, we usually call the patient at 3 months. Okay, 3 to 6 months. And home blood pressure you can check weekly once. in that case. So this would be the blood pressure measurement plan. Okay, so now this is there are now two tables and two slides which are really crucial to understand the blood pressures from different guidelines, because there are not only single guideline which suggest about the blood pressure and which are actually validated, because Jnc guidelines are internationally renowned, but in America they consider ACC and AHA, and in Europe they consider European Society of Cardiology, right? So these guidelines are need to understand, because in India we consider all. We do not have our own guidelines, and by the god grace, if everything goes fine, we'll come up in next 3 to 4 years, we will come up with our own guidelines, because WIHF, our World Youth Heart Federation, we are conducting the blood pressure cutoff studies in all over India, and I'm the director for research, so I mean under me only we are conducting the study in almost 1 million people, more than 5 lakh people to be considered for this blood pressure studies. And very soon, I mean this soon will be in at least 2 to 3 years, but yes, we will come up with some Indian cutoff guidelines, and Indian hypertensive guidelines very soon. So this work is in process, and we are doing that. But right now, as I'm telling, we have JNC, ACC, AHA, which are Americans, and ESC, which are Europeans. So according to that, they have also decided the blood pressure levels, like based on their population, based on like ESC decided the blood pressures based on the Europeans, and based on the Africans, and based on the Asians, because they have considered all the populations for their study. Americans also, they do the same, but mainly focused on American population, American continents, right? So 120 and 180 is normal for JNC and ACC, but in ESC it is optimal, right? In ESC, it is optimal, and 81 to 84 is normal, and for ACC AHA, this 120 to 190 phase or 190 slab is elevated, right, for ACC. And for JNC, 120 to 139 and 80 to 89 is pre-hypertension. For ACC, it is stage 1 hypertension, and for ESC, it is high normal, not hypertension, it is high normal. So they consider less than 140 to be normal or high normal, but they do not start medications directly, or they do not jump to any kind of modifications or hypertensive medications in this situation, right? So they consider it as high normal. And 140 to 159 and 90 to 99, like this, a slave of 20 mmHg is called stage 1 hypertension in JNC, stage 2 hypertension ACC, because Americans are tend to have more blood pressure. Americans are tend to get more complications in the lower blood pressure, right? Understand? So if their blood pressure is less than 140, 120 to 140, also they are considering stage 1. Why they're considering stage 1? Because they are getting more complications in that. So they try to treat those complications before this level only, right? And from 140 to 159 and 90 to 99, they consider it as stage 2 hypertension, because they get the more cardiac complications in that in that situation. They get more kidney problems in that situation. So that's why they try to treat those things earlier, right? And in ESC, the same situation, according to JNC also. I mean, in JNC and ESC, it is grade 1 hypertension, and more than 160, they consider it grade 2 hypertension, right? But in ACC, that is again in stage 2 hypertension, right? So BP drugs recommended only if 10 years cardiovascular risk is 10%. So in this, what we say, in our stage 2 hypertension, sorry, stage 1 hypertension or pre-hypertension, medications are only recommended if your cardiovascular risk is more than 10%. Cardiovascular risk is more than 10%. How to assess that cardiovascular risk? There are certain parameters, like if you have diabetes, if you have smoking, if you consume alcohol, and if you have hyperlipidemia, raised LDL levels, raised triglyceride levels. So there are certain there is certain scores which will tell you that your CV risk is less than 10% or more than 10%, right? So based on that, you can consider the blood pressure medications. Okay. Okay, so grade 3 hypertension is more than 180 and more than 110 mmHg of the blood pressure, and isolated systolic hypertension is known to be more than 140 or 90 mmHg. So grade 3 we are not considering, because grade 3 comes under hypertensive emergencies or hypertensive urgencies, right? So we have not considered here. Now the thing is, like with comorbidities, again, what should be the BP targets? What should be considered to be the normal blood pressure in different conditions? Okay, we have checked, like, okay, these things are according to ECC, or according to ESC, or according to JNC, less than 120 or less than 120/30 is normal, right? By different guidelines. But what is normal in different populations? What should be the blood pressure targets in different populations with different comorbidities? It should be also considered, right? So if your population is more than 60 years, if your population is more than 60 years, GNC 8 says that less than 150 and 90 of mmHg blood pressure could be counted to be normal. ACC says it should be less than 130/80. American Diabetic Association ADA has no comments on this. NKF is National Kidney Foundation. It has no comments on this. ESC says 130 to 139 could be considered as normal for the age of more than 60 years. So that means the people are considered to be elderly, and these elderly patients or elderly participants or elderly people could have less than 140. If they have the blood pressure less than 140, it is normal. It would be worrisome after it crosses the range of 140, right? Age less than 60 years, of course it could be, according to JNC 8 it could be less than 140, but according to ACC it is 130/80, and ESC also 130/80. Now the certain comorbidities like diabetes. In diabetic patients, we consider ADA. We all actually, ADA guidelines are worldwide used, American Diabetic Association. So they have considered, like, if the blood pressure is less than 140/80 or in 130/80 in some populations, though some populations are Americans, or though some populations are Americans, right? So in Americans, if it is less than 130/80, it is normal. With diabetes, if it is less than 140/80 in other populations, it could be considered as normal. And with CKD, like chronic kidney disease, so we consider National Kidney Foundation's recommendations. So they again tell the same thing. If it is less than 140/90, it is to be considered normal, and in the chronic kidney patients, right? And if it is less than 130/80, suggested, it is suggested that if it is less than 130/80 in some populations like Americans, again, that could be considered to be normal, right? And with cardiovascular diseases, of course, because these are the originated from the hypertension. Hypertension is one of the common risk factor for the cardiovascular problems, for heart attack, for heart failure, for any other conditions. So in that case, they are very cautious, and they consider it less than 130/80 mostly in American College of Cardiology, because these are the specific bodies which consider or which are working on cardiovascular problems: ACC and ESC. ESC for Europeans, and ACC for ACC and American Heart Association for Americans, right? So they consider the blood pressure to be less than 130/80 to be normal, right? To be considered as normal, right? So we should be aware of these, cutoff values, because we need it. See, if some patient, in layman language, I'll tell you, if someone is diabetic, or someone is having chronic kidney disease, if the patient is having blood pressure 138 or 136/86, normally it is blood pressure, it is like in the hypertension one category, or if it is in the pre-hypertension. But if the patient is already diabetic or chronic kidney disease, that means these problems are leading to this raise in blood pressure. Okay, these problems are leading the blood pressure to raise. So that is not the actual blood pressure, or that is actually influenced by these diseases, so that could be considered as normal, right? Understand that? So that's simple. And now CV risk factors, as I'm telling, epidemiological data clearly indicate a strong correlation between blood pressure and cardiovascular morbidity and mortality, and risk of stroke, myocardial infarction, I mean heart attack, angina, or heart failure, kidney failure, or maybe early death from a cardiovascular problems are directly associated with blood pressure. So blood pressure can cause heart attack. Blood pressure can cause risk. It is a risk factor for stroke also. It can cause heart failure. It can cause kidney failure. right? So you all know the blood pressure or high blood pressure or blood, hypertension is one of the the top most risk factor for stroke, right? So yes, that sentence will describe in the next slide. So what is the mechanism of action of hypertension? How we try to get that, how it raises? See, if we look at this diagram, look at from the back side, from the right side. Stroke volume, heart rate. Stroke volume and heart rate combinedly make cardiac output. Combinedly make cardiac output. Stroke volume and heart rate are the elements of cardiac output. Okay. And vascular structure means the diameter of your vessel, diameter of your arteries, and vascular function, how your lumen works, how your epithelial functions are good. So these things are actually the elements which can affect the peripheral resistance, right? If your lumen size is less, then your pressure will be really high. If your lumen size is big, if your lumen diameter is big, then your peripheral resistance will be less, right? So these all are directly associated with peripheral resistance inside the lumen, right? And then as we have described in last slides, like arterial blood pressure is cardiac output multiplied by peripheral resistance. So cardiac output and peripheral resistance are multiplying and making your arterial pressure, which is blood pressure, right? So these are the factors which actually lead to arterial pressure and are making your hypertension actually. So let's describe completely here in these slides. There are humoral mechanisms, right? Humoral mechanisms are like your rest system, renin, angiotensin, aldosterone system. There are natriuretic hormones. There are insulin resistance and hyperinsulinemia, which are actually your hormones, right? Your hormones which are directly raising your peripheral resistance or raising your blood volume, or these are associated with increased output, right? So these things could lead to blood pressure, right? And then neuronal regulations are there, like other regulatory components, vascular endothelial mechanism. As I was telling, this is the functions inside the lumen or inside the artery, right? And then other electrolytes and chemicals. What are the other electrolytes and chemicals? Let's see one by one, because pathophysiology is very must to understand. Check out this diagram, guys. So this is your lumen. See, this is your lumen. Okay, this is your lumen, and actually this is showing in the nephron, because blood pressure is actually primarily it is raised from the renin, from the nephron, from the kidney. Okay, this peripheral resistance is actually coming from the kidney, originated from the kidney. How it is originated from the kidney, I'll tell you. Because your nephron is generating the renin. It is secreting the renin. Renin is a component which is converting your angiotensin in your body into angiotensin 1. Renin is originated or secreted from the nephrons. From the nephron, a nephron is a part of kidney. Nephron is the smallest cell of your kidney. So in the nephron, renin will be secreted, and that renin will convert angiotensin into angiotensin 1. You can follow my cursor here. Angiotensin will be converted into angiotensin 1, and then angiotensin converting enzyme ACE, angiotensin converting enzyme, will convert this angiotensin 1 into angiotensin 2. Where? In the blood. In your blood, when renin is secreted and it has converted angiotensin into angiotensin 1, this will go to your blood, and inside the blood, angiotensin converting enzyme ACE will convert angiotensin 1 into angiotensin 2. Now angiotensin 2 is the responsible factor to increase your blood pressure. How? In different mechanisms. If it goes to heart, it will increase your contractility. See, look at this. If angiotensin 2 goes to your heart, it will increase the heart contractility. And if heart contractility is increased, means the flow of the blood or the pressure of the blood will be increased, and the cardiac output will be increased. Whatever the amount of blood is going out of the heart to the whole body, it will be increased. Then immediately when cardiac output increases, means blood pressure will increase. One mechanism by angiotensin 2. Another mechanism, if it goes to vascular smooth muscle, it will constrict the muscles. It will constrict the muscles. If it constricts the muscles, that means the peripheral pressure will increase. Peripheral pressure on the lumen of your artery will increase, and that pressure will increase your total peripheral resistance here, and it will cause high blood pressure, right? Third thing, if angiotensin works in your peripheral nervous system, it will increase, or it will, what we say, it will activate your sympathetic discharge, and that sympathetic discharge is directly associated with your total peripheral resistance, and it will increase that, and blood pressure will be increased, right? In another phase, if angiotensin second is going to CNS, it will work definitely on your central nervous system. It will release the vasopressin from there. Vasopressin will go to the heart. It will increase the contractility again, and it will increase the cardiac output, and it will increase the blood volume here. Look at here, it will increase the blood volume, and the blood volume again will increase your peripheral resistance and blood pressure, right? If it is goes to intestine or kidney or adrenal cortex, in that case it will actually work on your sodium water reabsorption or sodium water retention. So if it works on the sodium water retention, or if it is reabsorb the sodium and water, so what water will do, water will increase the amount of blood. Water and sodium will increase the amount of blood, and that amount of blood will be where it will go, it will be circulated through the arteries also, I mean arteries only, and it will be circulating through the arteries and through the lumen only. So it will increase the peripheral blood pressure, peripheral resistance, and peripheral resistance increment means raise in the blood pressure. So I hope you understand the mechanism of development of hypertension. It is all started from the kidney through the blood, and then angiotensin 2, and angiotensin 2 will go to all the systems of your body, and it will contribute to increase your blood pressure, right? Now let's discuss one by one. Natriuretic hormones. As I was telling, ANPs, the natriuretic hormones only, it promotes the natriuresis. Natriuresis is known to be loss of sodium from the body. So what and how it happens? Arterial myocytes, arterial myocytes are synthesizing and storing and releasing the ANP into the response to stress that lumen, okay? And it will cause the renal vasodilation. Renal vasodilation means the vasodilation in your nephrons in the kidney. Vasodilate means it will dilate the nephrons, and then it will actually trigger the renin secretion. It will trigger the renin secretion, and increasing in the blood flow and increasing in the GFR. And so when increasing in the GFR, definitely more sodium will be excreted. And when the more sodium is excreted, that it can again inhibit the opposite, it can show the opposite action also. It can it can show the opposite action also. It can work against the renin and sometimes against the angiotensin 2 also. So this is the work about the natriuretic hormone, how actually it works, right? So it can major work is like to increase the blood pressure. Major work is to secrete the renin, but the partially it also inhibits the renin secretion, and it opposes the angiotensin 2 conversion. Okay, so this is like contraindicatory, but the major part is participating in increasing the blood pressure directly. Okay, and how insulin resistance and hyperinsulinemia works. Why we are talking about this? Because diabetes is not considered to be as a major risk factor for hypertension, right? But it is metabolic syndrome, or known to be insulin resistance or hyperinsulinemia. It is known to increase your blood pressure. How? Increased insulin concentration may lead to hypertension because of increased renal sodium retention, because it enhances the sympathetic nervous system activity. Hyperinsulinemia can increase your sympathetic nervous activity, and we have seen that it could be done by angiotensin, or sympathetic nervous system activities can be increased or can be triggered even by the insulin resistance, or the increased insulin concentrations in the body, right? So again, sympathetic nervous system, if it is activated, it will increase your peripheral resistance, and it will increase your blood pressure at the end, right? Moreover, insulin has growth hormone like actions that can include the hypertrophy or vascular muscle vascular smooth muscle cells. Vascular smooth muscle cell hypertrophy means it can increase the size of the lumen. It can increase the size of the lumen. It can thicken that, it can thicken that vascular lumen or atrial lumen. So that atrial lumen will be thickened, and the peripheral resistance, it will not be flexible at that time. It will not be flexible, and that time it will not resist to the blood pressure, and peripheral resistance will increase. If the peripheral resistance will increase, means your blood pressure will be increased, right? So you have to understand that. So the exact mechanism is like the direct hormonal involvement and everything, they tell to like not known properly, but yes, it is indirectly approaching, and it is indirectly raising your blood pressure by raising the sodium renal concentration or reabsorption and sympathetic nervous activities, right? Neuronal regulations. So neuronal regulations are, there are a few pathological disturbances, and there are four major components which can lead to elevate your blood pressure, and those elements are autonomic nervous fiber and adrenergic receptors. Adrenergic receptors means it will directly work on the angiotensin conversion, okay, and then baroreceptors, and then central nervous system. As we have seen in the diagram, central nervous system, it will trigger your vasopressin release. Vasopressin release will go to your peripheral resistance increment, right? And peripheral resistance increment means your blood pressure raise. And the similarly, this is peripheral autoregulatory components. Peripheral autoregulatory components will work on the sodium and water reabsorption, right? Sodium and water reabsorption, and that is actually called blood volume pressure adaptive mechanism. Okay, peripheral autoregulatory components actually work under the volume pressure adaptive mechanism, and this mechanism lead to the reabsorption of sodium and water, and that is directly increasing your cardiac output. And cardiac output increment means your peripheral resistance increment, means your blood pressure raise. Okay, so this is the adaptive mechanism. Okay, and this is the again one more very important thing: vascular endothelial functions. Vascular endothelial involvement, how it is working. So there are some vasoactive substances which are synthesized by endothelial cell of your of your artery, right? From the lumen, there are some factors which are actually activating the vasopressin, which are actually actually affecting other parts. So excess vasoconstricting, okay, so deficiency of vasodilating substances. So vasoactive means it could be dilation, vasodilation, it could be vasoconstriction. So there are different things, in both the activities, both the activities of vasodilating and vasoconstriction. There are different enzymes, and there are different hormones which are released. So these vasoactives, let's see, in the deficiency of vasodilating substances, your prostacyclin or bradykinin will be released. Okay, in the deficiency of vasodilating substance, like prostacyclin and bradykinin, or excess of vasoconstricting substance like angiotensin 2 and endothelin 1, it can see prostacyclin and bradykinins are inflammatory factors, right? Inflammatory factors and inflammatory elements. So but prostacyclin is also a hormone. It is vasodilating hormone, right? Vasodilating hormone. And from the other side, when the excess of vasoconstricting substance like angiotensin 2, as we have seen in the diagram, it is directly associated with your blood pressure through different systems, like through CNS, through adrenergic receptors, through your heart, through your uh, your what we say, the vasopressin increase, and the increase in output, and from the sodium water reabsorption. So angiotensin 2 is the main factor which is associated with that. So vascular endothelium also contains the angiotensin 2. Okay, also it contains the angiotensin 2. How it contains, I mean, of course, after conversion in the blood, it will store some angiotensin 2, and it will be released. It will be released when where peripheral vascular resistance is disturbing. Peripheral vascular resistance is disturbed, right? So in that case, it will again work on this, and it will increase the blood pressure. So nitric oxide is produced in the endothelium, relaxes the vascular epithelium, and is a very potent vasodilator. Okay, so in that case, if you are suspecting, if you get the physiology of vascular endothelial improvement, sorry, involvement in the blood pressure increment, then nitric oxide could be used as a treatment, or nitric oxide could be used for the treatment. And this could not be given from outside, it is already available in your endothelium, right? It is already available in your endothelium, and it regulates, or it balances the effect of vasodilating prostacyclin and bradykinin, and it is also balancing the effect of angiotensin 2 and endothelin 1. Now electrolytes and others, as we have started from starting, we have started our talk from the salt and sodium consumption, and chlorine consumptions, NaCl. So these things are, electrolytes are very, very important part of the blood pressure, very, very important part of the raising blood pressures. How? Because high salt diets increase the circulating natriuretic hormone, which would inhibit the intracellular sodium transport, right? Intracellular sodium transport will be inhibited, will be stopped. That means the movement of sodium from cell to cell will be stopped, okay, will be inhibited, and it will increase in the vascular reactivity. It will increase in the vascular reactivity, and that sodium will go to the what we say, free fluid, right? It will go to the free fluid, and it will increase the vascular reactivity. When it is not moving from the cell to cell, when it is not moving from the organ to organ, from that, then it will be available, or it will be coming to the free fluid, and it will be increasing the vascular reactivity in the inside the cell in the free fluid. It will increase the vascular reactivity, and it will increase the peripheral resistance indirectly, and increase the BP, right? So lack of dietary calcium also can disturb the balance between intracellular and extracellular calcium, and it can again uh, alter the vascular smooth muscle functions. So calcium diet deficiency also can lead to your blood pressure, right? Blood pressure raise. So we always should take care of the calcium diets also. Along with reducing the salt, we have to increase the calcium in our diets. Potassium depletion may increase the peripheral vascular resistance. So again, see, potassium, sodium, and calcium, these three are the positive ions, right? These three are the positive ions. So when the potassium and sodium comes out of the cell, calcium goes inside the cell. Calcium balance that, calcium actually balance that, or regulate that functions, or regulate that hemodynamic situation inside the cell. So in that case, if anything comes down, like if the potassium comes down, because potassium always replaces sodium, potassium always replaces sodium. Sodium comes out of the cell, potassium goes inside, right? Potassium goes inside to make that hemodynamic to make that hemodynamic balance, or to regulate the hemodynamics of the cell. And actually this is related to cardiology, because it is in the phases, and that hyperpolarization or depolarization phases. So when potassium goes inside, sodium comes outside the cell, right? But if the potassium is less in amount, if the potassium deficiency is there, if the potassium depletion is there, that means the amount of sodium will be increased, and it can lead to the peripheral vascular resistance increment. It can lead to the increased peripheral vascular resistance. That means the blood pressure raise, right? So potassium depletion can lead to these things. And elevated uric acid also can lead to hypertension in actually chronic kidney diseases, right? So we should focus on the uric acid management also. What are the hypertensive emergencies? Hypertensive emergencies are extreme elevation in the blood pressure, extreme elevated in the blood pressure with target organ damage. Target organ damage is like you get some other complications related to hypertension, like intracranial hemorrhage, bleeding, right? Bleeding in the brain, intracranial hemorrhage. It could be acute left ventricular failure, heart failure, and it could be pulmonary edema, right? It could be heart attack, it could be eclampsia, or severe hypertension during pregnancy, that is that condition is called eclampsia. And then it could be encephalopathy, right? Patients actual balance is disturbed, or mental status is mental status is disturbed immediate suddenly. So that condition is called encephalopathy. And encephalopathy is not actually that, but it is it has the combination of multiple complications, like vomiting, gut disturbances, and swaying, or your nervous system disturbances, and your what you say, whatever your slurred speech, blurred vision. So encephalopathy is combination of multiple complications. So if you get the high blood pressure along with these target organ damage, that condition is called hypertension emergency, right? So hypertension emergency require an immediate and gradual reduction in blood pressure over a period of several minutes, right? Over a period of several minutes, using intravenous antihypertensive agents. So if we give tablets, it will show the effect in some more time. And actually tablets, or oral elements, or oral drugs cannot actually treat the hypertensive emergency. So we need intravenous drugs like nitroprusside or intravenous metoprolol. Okay, so these are the basic drugs to treat the hypertensive emergencies. But remember, when you get a patient with hypertensive emergency, you should not control that immediately. You should control it gradually within minutes. Okay, you should give these drugs bolus, not IV. Okay, not direct drugs, but in the bolus form, like over a period of few minutes, over a period of 5 minutes or 10 minutes. You should not inject the whole medicine immediately or in one shot. You should go for the intrabolus mode of administration of injections, right? Because in that case, if you suddenly broke the hypertension, if you suddenly broke that blood pressure, suddenly decreases, then your end organ damage, which has already happened, like encephalopathy, or it has already caused the ischemia, or it has already caused the hemorrhage, it will not be reversible. Remember this: if you broke the hypertension immediately or in one shot, your hypertension complications, whatever is end organ damage, will not be reversible. Okay, so if you want to reverse the situation, you have to calm down your blood pressure over a time gradually, right? So a reasonable goal to be gradually lower diastolic blood pressure should be less than 110 mmHg of diastolic blood pressure. First, let's cut down your blood pressure less than 110 mmHg, then less than 100 mmHg, then less than 90 mmHg. Okay, so that should be the cutoffs for the gradual reduction in blood pressure. Then after hypertension emergencies, there is something called hypertension urgencies. Hypertension urgencies are also high elevations in blood pressure, but without progressing the target organ injury. There is no target injury, but blood pressure would be more than 180 or 100, more than 180 by 100. So oral antihypertensive can work in the hypertensive urgencies, right? And you can control the blood pressure over a period of hours, not needed in the minutes, but over a period of hours you can reverse your blood pressure by the oral medication. So these are hypertensive urgencies without any target organ injury. Now how to diagnose the hypertension? That's important part, right? How to diagnose? First of all, I'll tell you from my experiences. First of all, whenever the patient is coming to the OPD, whenever the patient you are seeing anywhere in your office, in your OPD, any patient who is coming with the high blood pressure, first thing to ask is medical history. If the patient is having any medical history of diabetes, chronic kidney disease, or liver functions, or anything, you have to ask the medical history, any medication history, if the patient is taking any medication, and assess that if that medication is associated with the blood pressure raise, right? So check the medical history completely, whether your hypertension is primary. It will of course give you an insight to classify your hypertension, whether it is type 1 hypertension, or type 2 hypertension, whether it is primary hypertension or secondary hypertension, right? So you have to check the medical history and medication history thoroughly, and if it is needed, check the family history as well. if your family is having some hypertension problems or cardiac problems, or diabetic, or hyperlipidemia. So these things also will be considered in your medical history, because these things are directly or indirectly correlated with your blood pressure raise, right? And then check the blood pressure, as I told you, 3 sittings at least. After that, after following those instructions, patient should be sitting relaxed after 3 to 5 minutes of walk, and by the validated instrument. And patient should not smoke, or should not consume, should not has consumed the nicotine, or caffeine, at least for 30 minutes. Then go for the check, right? Go for the check of blood pressure, three values, and take the best of last two or all three blood pressures of, like SBP and DBP, right? Then next in the diagnosis comes risk factors, as I told you about hypertension. When you are checking, there are multiple risk factors of, like, personal history of CVD, family history of CVD, history of heart attack, history of heart failure, history of stroke or TIA, transischemic attacks, or history of diabetes, dyslipidemia, chronic kidney disease, or if the patient is a smoker or alcohol, he is taking alcohol, or how is the physical activity, if the patient's job can describe how he is going for walk, or how much he is working out in a day, right? So physical inactivity is one of the risk factor for hypertension. If you're not going for walk, if you're not going to do exercises or yoga daily, then your sedentary lifestyle can lead you to the hypertension very soon, right? So physical inactivity is again a risk factor, right? Then psychological aspects, your stressful life, your stress is again a major factor for hypertension, because it can it is directly associated with CNS and your sympathetic nervous system, or it will increase your vasopressin levels and increase your hormone levels, which are associated with the vasopressin, or what we say in the peripheral resistance, it will directly attribute. Okay, so we need to focus, and we need to focus on your psychological aspects also. So we need to consider these all things, right? And family history uh, of as I told you, the CVD, or hypertension or hypercholesteremia. So these things could be in the risk factors. You can assess all those, you can ask all those, and keep the a checklist for these. Then symptoms are not very, what we say, very visible in case of hypertension, if it is hypertension stage 1 or stage 2. But it could be visible, or it could be very dynamic to see in case of hypertension stage 3, or in case of hypertensive urgencies or emergencies. But in normal hypertension, it will not be visible much, right? But symptoms could be your chest pain, shortness of breath, palpitations, or claudication means the pain in your calf. Okay, and then peripheral edema, swelling of your calf, or swelling of your ankles. Okay, and then it could be headache, and it could be blurred vision, nocturia, or it could be hematuria, or maybe dizziness, swaying. These could be symptoms of the hypertension. So in that case, you can check out for the hypertension, or you can check out for the blood pressure, right? So some symptoms which are suggesting the secondary hypertension could be arrhythmias, like palpitation, again the muscles weakness, cramps, and flash pulmonary edema, sweating, palpitations, and then maybe frequent headaches, which is also known as fro pheochromi fro sorry, what is this, pheochromocytoma. Okay, so pheochromocytoma is like frequent headaches, not daily, but it would be frequent, right? And then snoring, or maybe daytime sleeping, or daytime sleepness is due to obstructive sleep apnea or obstructive sleep patterns, right? So these are the symptoms which can lead you to the hypertension, and that can be assessed. But remember, as I'm telling, the symptoms could not appear in hypertension 1 or hypertension 2. So best practice is to go for the blood pressure check, right? And then you can go for the physical examinations based on the your sign and symptoms, pulse rate, rhythm, or jugular vein pressure, apex beat, or extra heart sounds that can be done by the clinician. And your peripheral edema you can check, or radiofemoral delay you can check, or you can check your neck circumferences, BMI, to check out the metabolic syndrome and waist circumference. So these things can be checked in the physical examinations when you are assessing a hypertensive patient or hypertensive individual, right? So very important, what should be the lab tests we can do to check out the hypertension, or to get a clue on hypertension? Sodium, potassium, serum creatinine, and estimated GFR, or we can go for BUN also. Okay, then we can go for lipid profiles to check out the hypercholesteremia, and we can go for the fasting glucose to check out if the patient is diabetic or not, right? And then we can go for the urine test to check out the ketones, or to check out the other factors in the urine which can give you a clue of hypertension. Then to check out the other risk factor which is very important, CAD or CVD, cardiovascular risk, we can go for the 12 lead ECG will tell you about the arrhythmias like arterial hypertension, or it can tell you about the LVH, left ventricular hypertrophy, or maybe ischemia or heart attack. So it can lead you to the complications. It can lead you to the history behind the hypertension, history behind this raised blood pressure, right? So you can just go for it, go for these investigations while you are checking for the hypertension. So what are the goals of therapy? Before now, let's discuss about the therapies. Now we knew what is the hypertension, what is the pathophysiology, how it works, and what are the symptoms and signs, and how to diagnose the hypertension, what are the guidelines says, what are the different types of blood pressures in different populations. Those things are already now known. Now how to treat the hypertension, this is very important, right? Because now we got the hypertension, we have to treat it. So first of all, we have to fix the targets. What should be our goals for treatment? We have to treat the blood pressure to less than 140 or 190, or blood pressure less than 130 to 190 in the patients with diabetes or chronic kidney disease, right? We have to treat the patient to this goal. We have to reduce the cardiovascular risk and kidney morbidity, kidney related, renal related morbidity and mortality. We have to reduce the risk factor of stroke. That should be our goal while treating the hypertension. We have to achieve the systolic blood pressure goals, especially in the persons more than 50 years of age or more than 60 years of age. So that could be less than 120 mmHg, right? Because in these patients, your blood pressure is actually at a little higher side always. So our consideration should be at the same level, right? So less than 130, not less than 120, sorry, less than 130 by 80. That should be our goal in the persons of elderly age. Now, why it is very much necessary to control the blood pressure for cardiovascular events? Why it is necessary? Look at this. Look at this evidence. Look at this paper. What does it says? It was published in Lancet in 2002 by Levington, and this paper says if you reduce your blood pressure by 2 mmHg, your risk of cardiovascular events will reduce by 7 to 10%. See what a strong statement it is. What a strong statement. If you reduce your blood pressure by 2 mmHg, your risk of cardiovascular events will decrease by 7 to 10%. That means if you are decreasing your blood pressure by 10 mmHg, you will reduce your the risk of cardiovascular events by 50 to 60%. So you can understand how hypertension is associated with cardiovascular risks, how important it is to reduce our hypertension or blood pressure to control our cardiovascular problems. So you can understand this hypertension is directly associated with your heart attacks, with your heart failures, with your arrhythmias, right? Cardiovascular events. So that's why we need to control this blood pressure very much. And 7% for 7% for heart failures or ischemic heart disease, 10% reduction in stroke by reducing your blood pressure 2 mmHg, right? So understand this. This is very important, and this was done by by considering 61 studies in and meta-analysis, and considered 1 million adults, 10 lakh adults, and then they have concluded this statement. Okay, so facts about lifestyle, weight reduction. See, the trial of hypertension prevention produced an average weight loss of 3.8 kg in 18 months, in 1.5 years. So if you are reducing your weight by 4 kg, around 4 kg, 3.8 kg, you can reduce your systolic and diastolic blood pressure by 2.9 or 2.3 mmHg, around 3 mmHg. That means if you are reducing your weight by 6 kg or 7 kg, you are reducing your blood pressure by 6 mmHg. That means you are reducing your cardiovascular risk by almost 20%. Remember this. If you are reducing your weight, if you are controlling your weight, that means you are controlling your cardiovascular risk factors, you are controlling your cardiovascular diseases, right? So weight control, weight reduction is very important. Metabolic syndrome is very much dangerous for the cardiovascular problems, right? Remember. And then exercises. Again, the fact about exercise is very interesting. Increased physical activity, BP falls up from 7 to, up to 6 to 7 mmHg within 3 months. It is about, just if you are going for 30 minutes brisk walk per day, if you are going for 30 minutes brisk walk per day, or half an hour, just what we say it, cardiac exercises. If you go for cardiac exercises only for the 30 minutes per day, within 3 months your blood pressure will be controlled by 6 to 7 mmHg, and your 6 to 7 mmHg means your cardiovascular risk will come down 20 to 30%. So how important is doing exercises and yoga and pranayam, you can understand now. If you have a little concern about the health, you should focus on weight reduction, you should focus on exercises, because now you can see that, look at the facts, it is directly associated with your hypertension, it is directly associated with your cardiovascular risks. So if you want to reduce your cardiovascular risk, look at the weight reduction and exercises, right? Now, this is the treatment algorithm. Now I will come to the pharmacological thing. Pharmacological, treatment, and it also includes the lifestyle management. So, as we know, if initial blood pressure less than 140 and 90, it is normal. But if it is more than 140, 190, or if it is more than 160 by 100 mmHg, we should start lifestyle modifications and one agent. Like if it is more than 140 by 90, we can go for lifestyle management. But if it is more than 160 by 100 mmHg, we can go for one antihypertensive agent, one antihypertensive drug, right? And if your blood pressure is really more than 160 by 100 mmHg, we can go for even two elements or two drugs. Okay, so according to guidelines, I'll not drag you through this algorithm, but I'll tell you in basics the best suggested drug or the first line drug for hypertension in in the healthy, in the population with no comorbidity, or in the population with comorbidity, also in cardiovascular comorbidity. ACE inhibitors or ARBs are the first line choice. First line drugs are ACE inhibitors. Okay, previously it were CCBs. Sometimes we used thiazide diuretics, but recent guidelines, all the guidelines, not only one, all the guidelines, whether it is Jnc, whether it is American College of Cardiology, whether it is American Heart Association, or whether it is ESC, European Society of Cardiology, they all have come up with the new guidelines, and they say ACE inhibitors are the first line therapy for hypertension. Ramipril, enalapril, or lisinopril, it could be anything, but ACE inhibitors are the first line therapy, right? So if you are not controlling the blood pressure by one agent, then you can go for additional another drug, another category, which could be diuretic or CCBs. In that case, it could be CCBs or diuretics. So First line drug ACE inhibitors or ARB, then CCBs or diuretics can be added, right? Now check the blood pressure again and look at the adverse event. If your treatment is tolerated by the patient, or if you are achieved your target blood pressure, then continue with the therapy. But if you are not meeting that target, if your blood pressure is still at the higher level, if your blood pressure is still more than 160 by 100, or if it is not achieving by this control or by these drugs, then add one more therapy. Go for the triple therapy. Okay, go for the triple therapy. Include beta blockers also, or include if it is CCBs, diuretics, then include beta blockers also. Okay, you can go for the third line drug, right? And if you are having some adverse events like ACE inhibitors has angioedema, or cough, or congestion, this kind of serious adverse event, if you are facing with ACE inhibitors or ARB, you can jump to the second line drugs like diuretics or CCBs. You can start with those, right? Or you can shift the patient to those medications, right? Then again, if you are meeting this criteria with triple therapy or double therapy, double drugs, then continue the therapy. If you're not achieving this criteria, then go for the mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonist is spironolactone. Spironolactone is again diuretic, but that has the specific effect on mineralocorticoid receptors. Okay, which is work on the central hypertension, which works on the central arterial system. Okay, central arterial system, and that will definitely give you the good results, right? So that is also considered as the third additional drug, or at the end when it is not controlled by ACE inhibitors, ARBs, beta blockers, or CCBs, you can go for the mineralocorticoid receptor antagonist. Okay, the spironolactone. So let's discuss all the categories one by one. First is lifestyle modification. I'm just telling you lifestyle modifications. Even I have discussed in last classes with facts, but now salt reduction, of course. Salt reduction is very important because it is directly associated with your peripheral resistance. It is directly associated with your cardiac output. So salt reduction is very important, and salt reduction has some it should be, as Dr. G.D. Gupta sir was telling in starting, there is a range of salt, what you have to take in a day, that is 5 to 10 gram, right? If you're taking more than that, you have to restrict your salt because it can lead to the hypertension, it can lead to the blood pressure raise, right? And then healthy diet is very important. Healthy diet is what is actually considered to be healthy diet. You can check out DASH diet in the internet, but I will tell you what is actually constitute it actually involves the whole grains and fruits and vegetables, and poly unsaturated fats, or the less food with sugar, I mean less sugar in the food. It includes less sugar in the food, the limited sugar and limited salt and limited saturated fat, right? So we have to avoid these things from our diet, and we have to keep whole grains, fruit, vegetables, and poly unsaturated fats in our diet, right? Because vegetables are known to have high nitrates. And I was telling you, nitric oxide in your lumen can balance your angiotensin 2 levels and endothelin 1 levels, right? So it can control your blood pressure because it will be converted in your body only. Nitric oxide cannot be given from outside because that is a gas of laugh, right? Laughing gas, right? Nitric oxide. So we can't give from outside because that has certain side effects in your gut, in your larynx and pharynx. So you cannot give from outside. It should be generated inside your body. And how it will generate it? When you will take the green vegetables, when you will take the high amount of vegetables and beetroots, and so these things are generated in your body only from the healthy food. So healthy diet is very important, right? And you can take some kind of foods which has the high calcium and high sodium, like avocados, nuts, seeds, or legumes. You can take such things also in your healthy diet, right? And then healthy drinks. You should cut down your consumption of coffee and black or green, coffee and tea. You can shift out to the black tea or green tea in such cases, because it has the less nicotine consumption, and it will keep you away from the hypertension for a longer time, right? So other beverages that can be beneficial are hibiscus tea or pomegranate juice or beetroot juice or cocoa, that can be even considered in the healthy drinks, right? And then alcohol consumption should be moderated. Alcohol consumption should not be in the higher amount, it should be limited. And what is limit? It could be two standard drink or one and a half standard drink for a woman, like 10-gram alcohol per standard drink. So 20 to 15 15 to 20 gram of alcohol can be taken per day. It should be limited if you are taking, otherwise just leave. I mean, not to be taken, it's suggested not to be taken, but if you are a chronic drunker, if you are a chronic alcohol consumption, then you can just limit your alcohol consumptions to two standard drinks for a man and 1.5 standard drink for a woman. And the one standard drink means 10-gram of alcohol, right? And then weight reduction, as I told you, weight reduction is very important. And around 4 kg weight reduction in 3 months can reduce your blood pressure by 4 to 6 mmHg, and it can reduce your cardiovascular risk by 10 to 20%. Regular physical exercises, I told you about that, reduce the stress and induce mindfulness. See, chronic stress has been associated to high blood pressure later in your life. So it is very important to control your stress. Complementary and traditional medicines can be used, as these are used in Africa and other regions. And India, Ayurveda, I will say, is the best, but only in the initial stages. I mean, if you start Ayurveda from initial stages, there is no need to go for the second stages, because it will control your hypertension, it will control your raised blood pressure. With some lifestyle modifications, it will control, right? So go for the alternative and traditional medicines if it is needed. But I will suggest not to go when your blood pressure is really high, or you are in the second hypertension stage or third hypertension stage. It could be considered only in the stage 1, right? And reduce the exposure to air pollution or cold temperatures, okay? Because it has the negative effect on the body, or it has it has shown in some studies that pollution and cold temperature can lead to your blood pressure raise. So now drugs categories, as there are multiple drug categories in hypertension control. First is ACE inhibitors, and drugs are all pills, all suffix with the pills like captopril, enalapril, perindopril, ramipril, lisinopril. Then angiotensin antagonist, or we can say ARBs, angiotensin receptor blockers, right? ARBs, all sartans like telmisartan, candesartan, losartan, or olmesartan. So these are the angiotensin antagonists. And then calcium channel blockers, all dipines. And in the dipines also, it includes verapamil, diltiazem, nifedipine, felodipine, amlodipine. And then diuretics, two types of or three types of diuretics, which is a potassium sparing, high ceiling thiazide diuretics. And then beta blockers, propranolol, metoprolol, atenolol, carvedilol, or labetalol. And there are something called central sympathetic blockers. Okay, central sympathetic blockers. These are clonidine and methyl dopa, right? And some are alpha adrenergic blockers, which are prazosin and terazosin. And then some vasodilators like hydrolagine or minoxidil sodium. These are the drugs. But today we will discuss about four major categories. One is ACE inhibitors, ARBs, calcium channel blockers, and diuretics, just for you, so you can understand those things, how it works, and what are the side effects of those things, and what are the complications related to those, and how it actually works in hypertension. So before understanding the ACE inhibitors and ARBs, because these both works on the RAS system, renin angiotensin aldosterone system. RAAS is renin angiotensin aldosterone system, and that is directly associated with hypertension. So how it works? See, we have seen this diagram even before in the slide where we were discussing MOA, mechanism of action of hypertension. So how it actually works? See, from the kidney nephron, angiotensin will release into the blood after renin. I mean, in from the nephron, renin will come out, and it will from, see here, from the nephron renin will come out, and from the liver angiotensin will come out into the blood, and in blood renin will convert angiotensin into angiotensin 1, right? And then angiotensin 1 will be converted into angiotensin 2, and angiotensin 2 was raising your blood pressure through certain systems, through nervous system, through pituitary gland, through your kidney, through your heart, and through your sympathetic activity, right? So how these works? See, ACE inhibitors will work here. ACE inhibitors will inhibit this ACE, angiotensin converting enzyme. ACE inhibitors will work here, and it will stop ACE only. So angiotensin 1 will not be converted into angiotensin 2. That means if angiotensin 2 is not produced, so this whole activity will be inhibited. Whole activity will be inhibited. That means your things will not go up to that, will not raise the blood pressure finally, because your conversion of angiotensin 1 is stopped, inhibited by ACE inhibitors, right? So that's why ACE inhibitors are now first line drugs and very important, because these have the effect on before angiotensin 2 only, right? Now ARBs, angiotensin receptor beta blocker and angiotensin receptor blockers. So angiotensin receptor blockers will work like on all the systems, majorly on the aldosterone secretion in the kidney, okay, and on other systems also it works, because it stops angiotensin 2 to bind to those systems, because these are there are the receptors in every organ. In every organ there are the receptors, and those receptors will bind with angiotensin 2, and then only angiotensin 2 will start reacting, or start reacting to those things and increase in the blood pressure. But when beta blocker, sorry, ARBs will come there, ARBs will bind already to those things, and in that case your angiotensin will not be bind to those receptors, and these reactions, or these actions of angiotensin 2 will be stopped, right? So that is ARBs. So you understand the mechanism of action, but still, let's see. I think this is done here. This theory is just about those things only, right? And then ACE inhibitors. So ACE inhibitors are usually used to control the blood pressure 1 and type 1 hypertension, and in type 2 hypertension also we can use. And what are the benefits of using ACE inhibitors? It does not interfere with cardiovascular reflexes. They have no interfere, even they are beneficial for the cardiovascular events. And these ACE inhibitors are not associated with asthma patients, because see, if you are taking beta blockers can enhance your asthma attacks. It can enhance your, asthmatic, it can exacerbate your asthma. But ACE inhibitors or ARBs do not do this. ACE inhibitors and ARBs are safe in asthmatic patients as well, and it do not decrease your potassium level. Remember, it is very important, because see, diuretics can decrease your potassium level or increase your sodium levels. In that case, ACE inhibitors are good, because these have no interference with potassium levels, right? It does not cause ACE inhibitors do not cause lethargy or weakness or sexual dysfunctions like other diuretics or some other endothelial dysfunction drugs, endothelial problematic endothelial related drugs. So this can be good. So that's have the benefits over other drugs. ACE inhibitors have the multiple benefits over other drugs, right? So Lene said ACE inhibitors reduce the risk of cardiovascular mortality caused by hypertension. So it has the double benefit, one in the cardiovascular mortality, and one itself it is reducing the hypertension. So ACE inhibitors are the first choice for hypertension treatment, right? Now work, as I was telling, it is stopping the ACE, and ACE is responsible for angiotensin 1 conversion to angiotensin 2. So it is stopping ACE only. Done. Your blood pressure will be uh, relieved. Your blood pressure will not increase, because angiotensin 1 is not converted into angiotensin 2. Understand? So it is simple. Same it is described here. And drugs in ACE inhibitors are ramipril, enalapril, lisinopril, benzapril, enalapril, or sorry, I think it's repeated, fosinopril, and moxapril, perindopril. But the most used drug here is ramipril and enalapril. Why? I'll show you here. Let's check here why enalapril and ramipril are most used drug. Because see, look at this. If the people of hypertension are with heart failure, enalapril has the top effect. Enalapril has the effect in reducing deaths. See, reducing deaths, improving quality of life. So enalapril is reducing deaths. Enalapril is improving lifestyle. Okay, not other drugs. Here in this category, only if we check for heart failure, captopril is also reducing deaths and improving quality of life. Ramipril and tredolapril also, reducing deaths and increasing quality of life in heart failure patients. When it comes to the patient with heart attack, reducing deaths in heart attack, captopril is reducing deaths with heart attack. Ramipril and tredolapril also reducing deaths with heart attack. But when it comes to the patient with other risk factors like stroke, captopril is there, but enalapril is also there, ramipril is there, tredolapril is there. But in the, reducing the risk of heart attack, these are there. But in reducing the reducing the deaths in stroke, reducing the deaths in stroke and diabetes, reducing the deaths in stroke and diabetes, captopril has no effect, but ramipril has the effect. Ramipril is the only drug which is recommended to reduce deaths or to reduce the comorbidities in patients with diabetes and heart attacks together, diabetes and CVDs together. So Ramipril is to be considered as best drug from this category, from the ACE inhibitors category, right? So this is to understand here. And then enalapril. Why enalapril? Because enalapril is very much recommended in kidney disease. It is not affecting the kidney problems, and when the patient have kidney problems along with the heart attack, enalapril is recommended, or ramipril is recommended. That's why I told that enalapril and ramipril as the best drug in this category. So remember, these things are very important to understand which drug to choose and in which population what drug will work, right? So that's why it is important, right? So enalapril and ramipril, and if after that we can go for captopril, right? Lisinopril is also good, but only in some certain population, like the patients who have heart attack and somewhat diabetes and stroke, but not in the deaths, not reducing in the death role, right? So the recommended drugs are enalapril and ramipril here. What are the adverse effect? First dose hypertension is the major, what we say, the majorly appeared adverse effect of ACE inhibitors, because initial dose can lead to the hypotension in the patient. Okay, it can lead to the hypotension. So after first dose we have to monitor it very much when we are giving ACE inhibitors to the patient, or we should start with a lower dose. We cannot go for the higher dose directly. We can start with the lower dose in the patient with hypertension, and when we are considering ACE inhibitors or ARBs, it is with both. And ACE inhibitors can show the cough, persistent, dry, irritating, non-productive cough can develop with all ACE inhibitors due to rise in bradykinin. Okay, because it raises the bradykinin, that's why it is there, and this can occur in 5 to 10% of the patient, and it is more common in women and elderly cough. And other side effects are hyperkalemia, means potassium level can be raised in this situation by ACE inhibitors. Okay, and it can create some problems to the kidney, and it can associated with the renal failure also, and sometimes due to hypotension it could be fatal to the patient, right? Severe hyperkalemia or severe hypotension could lead to renal failure or death. So drug interactions, other antihypertensive drugs we cannot give in multiple drugs if it is not needed. We could not give with the medications which are increasing the potassium, like which are suppressing the aldosterone. So it can again lead to hyperkalemia. So we should not give with the drugs which are already there to increase the potassium, right? We should not give with the lithium because it can lead to lithium toxicity. We could not give with alloprenol and NSAIDs because it can reduce the antihypertensive activity. What should be monitored? Weight loss could be monitored, smoking should be quit, and we should decrease the alcohol intake while taking ACE inhibitors. Otherwise, it could, definitely it will reduce the effect of the medicine, right? We should monitor potassium levels, creatinine, and BUN. Why potassium levels? Because ACE inhibitors are tend to increase the potassium levels in hypertensive patients, right? When we are giving the ACE inhibitors, right? And monitor the patient for decreased fluid volume. How? By checking the blood pressure, or by looking at the excessive sweating, maybe diarrhea, it can cause vomiting or dehydration. So in that case, we can stop the drug, or we can find an alternative, or we can treat the complications like diarrhea, vomiting, and dehydration, right? So again, we can monitor for the first dose hypertension. We can continuous, and if it is given with the diuretics, there are the high chances of getting first dose hypotension. Okay, and we can educate the patient about the drugs. So this is the summary of ACE inhibitors. ACE inhibitors are known, or to be known as April, right? So captopril, ramipril, enalapril, fasenopril, lisinopril. And remember one more thing: medication uses for ACE inhibitors include, we can include the indications of, this is very important, you can even understand this: home care makes patients definitely strong. This is a sentence you have to remember: home care makes patients definitely strong. That means these are the indications. H remembers, H goes for hypertension, care ka C goes for congestive heart failure, make M goes for myocardial infarction, P goes for prophylaxis for cardiovascular risk subjects, D for diabetic nephropathy, and S for scleroderma crisis. So ACE inhibitors can be given in all the conditions, even except hypertension. Hypertension is just one, but ACE inhibitors can be used. See, I'm telling, congestive heart failure, if you go for the guidelines, if you check out the guidelines, ACE inhibitors are the first line choices for heart failure. Not only for the hypertension, but ACE inhibitors are the first line drugs for the heart failure as well, because these have the best effect on, these are the reversible drugs for heart failure. And if you check out the side effect of ACE inhibitors, just remember captopril. Just remember one drug, captopril. C goes for cough, A for allergic reactions, P for potassium elevation, T for taste change, sometimes O for edema. Angioedema is very important and major side effect of ACE inhibitors. And P for again photosensitivity, R for renal failure, and I for indigestion, L for hypotension, low blood pressure. So if you remember, if you want to remember side effects of ACE inhibitors, just remember captopril, and just expand the captopril, you will get all the side effects related to ACE inhibitors, right? So these are just tricks to remember the things. Now ARBs are having similar effects to ACE inhibitors, but a little different in mechanism, because ACE inhibitors stops or inhibits the ACE, angiotensin converting enzyme, and ARBs works on the different sites to stop binding of angiotensin 2 on the receptors, or on the system, or on the organs, in the organs, right? So that's how it stops the or reduce the blood pressure by stopping angiotensin 2 to binding to the receptor. That's okay. Sorry, here if you read it, it says simply what I'm saying. Newer class of antihypertensive drugs, ARBs, were developed to overcome several deficiencies of ACE inhibitors. So ACE inhibitors had some deficiencies, or ACE inhibitors had some complications with them. So just to overcome those complications, the ARBs, when ARBs were introduced, right? ACE or angiotensin 2 receptor blockers help relax your veins and arteries to lower your blood pressure and make it easier for your heart to pump the blood. So again, the same thing, it is reducing your blood pressure in like in simple words, right? Okay, so I think it will confuse you if you read everything, because it is not, it's in the technical language. So yeah, major thing is here, this sentence, second last sentence: angiotensin 2 receptor blocker blocks the action of angiotensin 2. That is important, because it angiotensin receptor drugs will go and bind to the receptors or the binding sites where angiotensin 2 is going to bind. Okay, so it stops angiotensin 2 to bind to the receptors, and it will affect, it will actually, what we say, the it is dismissing the effect of angiotensin 2 on the system. That's all. So there are two types of receptors. One is 81 and 82. Okay, angiotensin receptor 1 and angiotensin receptor 2. So angiotensin receptor 1 is actually very important because it will be there in your blood vessels. It will be there in the kidney, adrenal gland, and heart, liver, brain, everywhere. 81 receptor is there, and the legends are available for all the drugs. 82 receptors are important, but these are not much used, because see, 82 receptors are newly we can say the newly founded, and the drugs associated with these are also in the trials. But 81 receptors are are very important and can be considered for all the drugs. Again, these have the certain what we say benefits, like the patient who do not tolerate ACE inhibitors or who gets the angioedema and cough after ACE inhibitors can be given with ARVs. And again, benefits: it do not interfere with cardiovascular reflexes, it do not interfere with the patients with asthma like beta blockers, and it also do not cause does not cause the lethargy, weakness, or sexual dysfunctions, and it also helps in reducing cardiovascular mortality. Okay, same thing you can see, it is stopping the angiotensin 2 to binding to the receptors. And if angiotensin 2 is binding to the receptor, it will cause your blood pressure raise by these reactions, by aldosterone release, by sodium water retention, by vasoconstriction, by myocardial fibrosis. So if it is not binding to the receptor, it will automatically dismiss the effect, or it will help in decreasing your blood pressure. MOA, written by suffix sartan: candy sartan, aprosartan, irbesartan, losartan, olmesartan, telmisartan, valsartan, or valsartan. If you check out, losartan and valsartan are the drugs actually known for the heart failure, but telmisartan and olmesartan are the drugs which are most used in the hypertensive patients. And doses, you can see, losartan can be given from 50 to 100 mg, and telmisartan and olmesartan can be given 20 to 80 or 20 to 40 mg, right? And if you look at the bioavailability of telmisartan is really good, 43. Irbesartan is there, but why we do not give irbesartan? Because it is not exactly showing in the clinical trials, not showing the good effect in clinical trials. Bioavailability is good, but clinical trials does not show irbesartan. That's why telmisartan and olmesartan is good. Adverse effect with ARBs: dizziness, headache, hyperkalemia, again similar to ACE inhibitors. And then other side effects could be infrequent ADRs, or rashes, diarrhea, dyspepsia, or first dose hypotension, and decreased hemoglobin sometimes, renal impairment, nasal congestion, right? Drug interactions. ACE inhibitors cannot be given with ARBs. ARBs should not be given with NSAIDs. With diuretics cannot be given. Cyclosporin can cause severe hyperkalemia, so cannot give with cyclosporin also. And with potassium supplements, as this is increasing the potassium level, we cannot give with the potassium supplements. Monitorings: blood pressure, hypotension, or hyperkalemia. For calcium, potassium we can check, allergic reactions we can check, and we can go for serum potassium also, right? Now let's come to the diuretics. So diuretics are different types, right? One are high efficacy or loop diuretics, which are actually potassium depleting. That means these drugs will reduce the potassium levels. These drugs will reduce the potassium levels. High efficacy diuretics. Examples: furosemide, bumetanide, and torsemide. Moderate efficacy diuretics are also potassium depleted, like thiazides or thiazide related diuretics. Thiazides are hydrochlorothiazide or bendroflumethiazide, and thiazide related diuretics, metalazone or indapamide, right? And low efficacy drugs are potassium sparing, means they can increase the potassium. Potassium sparing means they can increase the potassium, and in that, aldosterone antagonists are spironolactone, eplerenone, right? And some drugs which are inhibiting the renal sodium channel, and like amiloride, okay, amiloride or triamterene. Trimetrin also is one of the potassium sparing diuretics. And then there are some more diuretics in the category of osmotic diuretics like mannitol, and like carbonic anhydrase inhibitors like estrazolamide or dorzolamide. So these are the drug classifications based on the potassium, decreasing potassium or increasing potassium, and based on the uh, receptors, how and where they are working actually, right? So you can check out, this is the a nephron or the whole kidney absorption system. Here you can check, it has started from here, if you check out. Okay, so from the medulla itself, if you check out here, mannitol will work, and in the loop sorry, in the cortex of medulla, acetozolamide will work. And if you go a little out, because it will reduce the sodium reabsorption and potassium reabsorption, if you go to the loop of Henle, if you go to the descending limb of loop of Henle, you will check mannitol is useful here. If you go to the ascending limb of loop of Henle, furosemide, bumetanide or torsemide will work here, and it will stop the sodium and potassium sodium reabsorption, right? And if you go to the upper part, proximal tubule here, if you go to the proximal tubule, chlorothiazides will work, that thiazide diuretics will work here in the proximal tubule. So you can just locate your diuretics, where it is actually working and what is the work, right? So as ascending loop, furosemide, bumetanide, torsemide is working. Descending loop, mannitol. Proximal tubule, chlorothiazide, right? And when you come to the collecting duct, all potassium sparings will work here, because here potassium will be reabsorbed. Here, right? So eplerenone, spironolactone, amiloride, all will work at the collecting duct, and it will reabsorb the potassium, right? So that's how and where it works. This is just thing. And you can check out the dosings also. Furosemide is a loop diuretic. 20 to 400 mg we can give, up to 400 mg. Onset of action is 1 hour to 5 minutes. And torsemide dose is 10 to 200 mg. Bumetanide 1 mg to 5 mg we can give. And metolazone, chlorothiazide, hydrochlorothiazide 12.5 or 25 we can give. So these are just the dosing of the drugs, right? Spironolactone can be given 12.5 to 50 mg. So so these are just elimination life or half life. So these are about all the drugs of diuretics. So here you can check out about the uses or side effects of the diuretics. If you check out, let's go one by one. If you check out the loop diuretics, furosemide and ethacrynic acid, if you check out here, one sec. Yeah, if you check out the side effects, loop diuretics, it will cause hypokalemia, right? It will cause hypokalemia and hyperuricemia, ototoxicity, or hypocalcemia. Uses, it can be used in hypertension, it can be used in acute pulmonary edema, it can be used in acute renal failure, it can be used in heart failure. Let's come to the thiazide diuretics. It can be used in hypertension and congestive heart failure. It can be used in nephrolithiasis. It can be used in nephrotic diabetic insipidus, type 1 diabetes. We can use thiazide diuretics. Side effects, again, hypokalemia, hyperuricemia, hyperglycemia, or hyperlipidemia. Potassium sparing diuretics, here if you come, amiloride or spironolactone, potassium sparing, these are reabsorbing the potassium, so these can increase the potassium level. If you check out, hyperkalemia is the major side effect, hyperkalemia and acidosis. And utilization, again, a congestive heart failure, we can use spironolactone. And as a third level drug or third category drug, we can use for hypertension also. Amiloride is not recommended in hypertension, but it is recommended in nephrogenic diabetes insipidus and other nephrotic problems. If you look at osmotic diuretics, acute hypovolemia it can cause, because it will eliminate the water content, and it does not help in sodium water retention, right? And uses, can be used in oliguric status or intracerebral pressure. We can use osmotic diuretics, and estazolamide or dorzolamide, CA inhibitors. We can just use in glaucoma or acute mountain sickness when the patients are going to climb mountains or climb bus. They usually use CA inhibitors, estazolamide and all, to avoid that acute mountain sickness or metabolic alkalosis, right? Side effects could be hypokalemia and paresthesis, or maybe renal stones can be developed by estazolamide. So we should avoid these things in renal stones problem, right? Yeah, about the things. Now, last category I want to tell you about the CCBs. So calcium channel blockers or calcium antagonist prevent calcium from infiltrating the cell of the heart and blood vessel wall. So it relaxes and widens the blood vessels of the heart within the arterial wall, and it is promoting the lower blood pressure. When the calcium is not infiltrating to the cell, that means your potassium level will be there, and potassium levels are tend to create the tend to reduce the blood pressure by reducing the peripheral resistance, because it works against the sodium, right? Calcium channel blockers can slow the heart rate, it can relieve the chest pressure and control the irregular heartbeat also. That's why some of the calcium channel blockers are the first line drugs for arrhythmias, right? So they are the first line antihypertensive drugs. They were the antihypertensive. Sorry, this is a wrong statement here. I think I have, I did not check it. They were, not are. Okay, I'll just to make it. Yeah. So they were the first line antihypertensive drugs before 2018. From 2018, all the guidelines have come and they have supported ACE inhibitors as first line therapy for antihypertensive. Okay. Monotherapy with CCBs is effective in all about 50% of all about 50% of hypertensive patients can be treated with monotherapy with CCBs, but not right now, because CCBs are known to produce a pedal edema and congestion and other problems also. It can also be used to treat angina. Types of calcium channel blockers. One is phenylalkylamines, and second is benzodiazepines, and third is dihydropyridines. So benzyl alkylamines are the the first generation drugs, not first line, first generation drugs, verapamil. Then they have developed diltiazem, that is benzodiazepines, are second generation drugs. Then in the dihydropyridines, there were some different generations. So in dihydropyridines, first generation is nifedipine. Then they have developed again nicardipine and felodipine as second generation drug. After this, they have improved that content, they have improved that element, and they have come up with the amlodipine, which is third generation drug, and very important, very good. But amlodipine has some side effects like peripheral edema or congestion. So to avoid that congestion or peripheral edema, amlodipine also has improved to cilnidipine and benidipine, which are fourth generation drugs. So now the best effective drug is benidipine and cilnidipine, but still treatment of choice, if we say, all the clinicians, they believe in amlodipine, right? They believe in amlodipine. If you check out practically, if you check out in the general practice, amlodipine is preferred. So how we know them? There are three different types of categories. So how we know them? We can know them by very nice drugs. V for verapamil, which indicates the first category, phenylalkylamines. N is 1 for dihydropyridines, nifedipine, and diltiazem is from the benzodiazepines. So we can understand these calcium channel blockers, all the categories, by V and D, very nice drugs, right? And these are actually very nice because verapamil and diltiazem are the drug of choice of all time for the arrhythmias, for the SVTs can be converted by only diltiazem. Okay, this is the drug of choice for SVTs, supraventricular tachycardias. For the arrhythmias, only verapamil and diltiazem are used, no other drugs. So that's why these are really good drugs, and these can even inhibit the immediate death or immediate succumb of the patient from arrhythmias. So that's why these are really nice drugs. And previously they were the first choice for hypertension as well. So they have even differentiated the drugs based on the action duration, short acting or long acting. So short acting like nifedipine, diltiazem, verapamil. So long acting are all dipines, like amlodipine, felodipine, and now cilnidipine and benzodiazepine. Mechanism of action is simple. It increases the time that calcium channel are closed. So relaxation of arterial smooth muscles, but not much effect on venous smooth muscles. It has the significant reduction in afterload. It has significant effect in afterload. That means the cardiac output will be controlled better and it can reduce the blood pressure better. And uses of CCBs, you can use in angina pectoris, in hypertension, and in use of supraventricular arrhythmias like atrial flutter, atrial fibrillation, or paroxysmal supraventricular tachycardia. So this is the best choice of drug in the arrhythmias. So here we can see the doses and bioavailability and elimination half-life. So the best choice of drug is amlodipine again because of bioavailability of 64 to 90%, protein bound is 99%, and elimination life is 30 to 50 hours. Single dose of amlodipine is enough. That's why amlodipine is the best choice, and everyone believe or rely on amlodipine, right? So adverse effect could be postural hypertension. It can cause palpitation, and edema is the major side effect of CCBs. Then again, AV block. It can cause the AV block, atrioventricular block. So we should be take care of AV block by taking ECGs, and we should monitor edema every week or every 2 weeks. We should look at your feet or ankles to check out the edema. So contraindications, we should not give ACE inhibitors in, CCBs in heart failure or in bradycardia patient because it can reduce down the heartbeat again. We should not give in the patients with atrioventricular block because it is causing the atrioventricular block, AV blocks, right? We should not give, with dihydropyridine calcium channel blockers in patients with uncontrolled heart failure, right? Monitoring heart rate, definitely, because it is reducing the heart rate, it is controlling the heart rate, heartbeats. Blood pressure for the hypertension. Anginal symptoms, if patient is showing the signs of heart failure, we should not give. So we should monitor these things and other side effects like hypertension. So thank you very much for this, and we have come up with something called summer school. If students are interested, they can come up and join our summer school. This is a 1 month training plus 4 weeks additional course. Okay, so thank you very much for the interesting talk and giving me the opportunity. Again, ISF College.
Yeah, thank you so much, Dr. Ajit Singh, sir. I have been watching since last couple of hours, and I have seen that you have given tirelessly, even though not a single glass of water you have administered. So congratulations to you, sir, and from ISF College of
Thank
Pharmacy,
you very much, sir.
we are grateful for your presence on this occasion. This is how a disease awareness, or as a medical paramedical student, we should go with the fact files till past to present and the future predictions. So before ending up, I would like to have the uh, remarks and blessings of Professor GD Gupta, sir, for the
I
same
hope
session.
I hope I met your expectations, sir. That's
Oh,
my best
Exactly.
thank
reward.
you very much, Dr. Ajit ji. No doubt, very rich session, and you have taken for each and everything because I know that the whole of the body system this is depend upon the blood circulation, blood pressure, and in those days, if I am not wrong, two disease, more than two, you can three. One is the
Yes,
arthritis, blood pressure, and diabetes. These
yes,
three diseases they are very common, and most probably if you can visit any house and throughout the world, at least one patient in each home, at least
yes,
one. And
yes,
during this the pandemic situation, lot of stress, tension, depression, so these things is the also creating. So you have covered all parameters which are related to the scientifically valid and technically very sound, because this is the essential to the end you can say listener and end user, so they can come to know each and everything in a very systematic manner. And I feel that this we have the taken with the full of the length of the interactive session. So
thank
thank
you,
you
sir.
very much, Dr. Ajit ji, and I hope that very soon we can meet together at
Yeah,
when
sure,
we
yeah.
the things to be the as you can say favorable. So we can
Yes,
we want to
definitely.
the here one of the conference with the physical parameters so that person they
Sure.
can be interact because I know that जो मेरा अपना एक मानना एक चलता है कि आफ्टर सम टाइम आज हम जिस तरह की सिचुएशन देखते हैं कि आफ्टर दैट जो ह्यूमन पर्सन का जो इंटरेक्टिव सिस्टम था आफ्टर
Right.
दिस पेंडेमिक व्हाट हैपेंड, क्योंकि हम इतने ज्यादा आइसोलेटेड हो गए हैं, सुपरफिशियल हो गए हैं और फोटो ही से काम चल रहा है। एंड
Correct.
लाइक दैट मुझको नहीं कहना चाहिए कि जो भावनाएं एक व्यक्ति जीवित व्यक्ति के लिए होती थी और एक मृत व्यक्ति के लिए होती थी वो कहीं ना कहीं फैंसी फॉर्मेट में चला जा रहा है और एक्सेप्टेड मतलब ये लगता है ठीक है ये मर गया तो ठीक है, ये जिंदा है तो ठीक है। तो इस टाइप
True.
से थिंग। अच्छा, एक जैसे जो ग्रुप्स हैं आज हम ग्रुप्स में देखते हैं तो अच्छा बंदा पढ़ देखता ही नहीं है कि कौन गया और कौन आया, वो दो हाथ जोड़ के आरआईपी कर देता है, कई बार तो जिंदा को लगा देता है कि वो कुछ कह रहा है। तो वी आर द टू मच सुपरफिशियल। तो आने वाला
True.
टाइम हेल्दी हो एंड वी कैन कम टुगेदर। तो जो
Definitely.
मानसिक ये भी एक जूसेस का बहुत बड़ा पार्ट होता है व्हेन वी
Definitely.
इंटरेक्ट टू ईच अदर। तो ये हमारे जो ब्रेन के जो रिसेप्टर्स हैं और इनके जो जूसेस सीक्रेशन होते हैं इसीलिए हमारे यहाँ अलग अलग भाव बनाए हैं, लव अफेक्शन बनाया है और आपका फियर बनाया है। ये सारे अपने तरह के रिसेप्टर हैं जो इनसाइड ऑफ द बॉडी दे आर द सीक्रेटिंग। और जो
Right.
हमारे बहुत सारा नर्वस सिस्टम है जिनको एक्साइटमेंट की तरफ ले जाता है या जिसको अपन एफोरेटिक इफेक्ट कहते हैं एक अच्छी फीलिंग की तरफ ले जाता है। तो ये सारी चीजें आने वाले टाइम में है हो। एंड आई होप दैट कि एक हम लोग मिलकर के एक ओनली फॉर द कोविड, आई नो दैट एट दैट टाइम इट इज वेरी डिफिकल्ट टू गिव एनीथिंग अबाउट द कोविड सिचुएशन। लेकिन मेरा ये है कि 30-40 क्वेश्चन डिफाइन क्वेश्चन जैसे एक जगह की आई कि लोग जो है धुआं को लेकर के पूरे गांव में घुमा रहे हैं कि वायरस खत्म हो जाएगा। एक फोटो आती है कि 50 लोग गोबर का लेप लगाए बैठे हुए हैं कि कोविड खत्म हो जाएगा। एक जगह है वो कंपनी अपनी ब्रांडेड करके कि ये गौमूत्र है, आप 10 ml रोज सेवन करिए कोविड खत्म हो जाएगा। तो लाइक दैट तो ढेर सारे भ्रम वैक्सीन को लेकर के भ्रम। और जो हमारे यहाँ ऑब्वियसली वी आर डेडिकेटेड, फिर जो जितने भी जो व्हाट्सएप ग्रुप आ रहे हैं तो इन सबको मिला करके ओनली दैट्स वन कि हम 100 एक क्वेश्चन उनसे फाइंड आउट कर लें कि ये फैक्ट्स एंड फाइन है। जैसे कि ये नहीं हो सकता है, हो सकता दैट्स ओके। मैं ये कहता हूँ आप जिस धर्म में बिलीव आपको फायदा हो रहा है यू कैन डू, लेकिन वो सब पर लागू नहीं हो सकता है क्योंकि ये बॉडी का एक
नहीं हो सकता है
कंसेप्ट
बिल्कुल।
ऐसा है कि व्हाट यू कैन एक्सेप्ट। अभी आज आपको एक खबर बताएं, आप चौंक जाएंगे और जब मैंने इसको देखी आई आल्सो सरप्राइज। वन ऑफ द बिग न्यूज, और वो बिग न्यूज ये है, आपने पढ़ा है रेमडेसिविर का जो अभी आया है एक, मैं अभी 1 मिनट में आपको
एमपी
बताता हूँ ताकि मैं चाहता हूँ लोग इसको देखें।
Out of medicine list,
डाला है उन्होंने
WHO.
न्यूज ये डाली है कि जो रेमडेसिविर है, और एक खबर है मैं पढ़ देता हूँ, 90% पेशेंट रेमडेसिविर इन एमपी बीट कोविड।
बीट
बताइए,
कोविड,
ये
यस।
इंग्लिश अखबार की बड़ी बड़ी न्यूज है। तो क्या बताना चाहते हैं हम कि हम फर्जी कर दें, जो नकली दवाई लगी उससे सब कोविड पेशेंट ठीक हो गए हैं, और एक इंग्लिश पेपर कवरेज दे रहा है। यानी
राइट।
कि हमारी कंट्री में पढ़े लिखे लोगों का क्या होगा। ठीक है,
बिल्कुल।
प्लेसबो दैट्स ओके। और उसको इस तरह से पॉपुलर के बीच में तो किसको
करेक्ट
सपोर्ट
सर।
कर रहे हैं, टू whom? दोज पर्सन हु इज डूइंग द रॉन्ग कंसेप्ट। दूसरी
करेक्ट सर।
जगह वहां का सीएम कहता है दूसरी जगह का कि ऐसे लोगों को जो अटेम्प्ट टू मर्डर के अंदर में इनको बंद करना चाहिए, और दूसरी खबर ये
एग्जैक्टली।
लिखी जा रही। तो इस
एग्जैक्टली।
टाइप की चीजें मेरा एक कंसेप्ट है। तो मैं कोसे जी से रिक्वेस्ट करूंगा कि हम एक इस पर, क्योंकि वी आर नॉट गिव द एक्सपर्ट कमेंट, कोई कमेंट नहीं देखें। जो न्यूज चल रही हैं, जो फेक न्यूज चल रही हैं, ओनली वी कैन डिस्कस ऑन सम ऑफ द पॉइंट। तो अजीत सिंह जी के साथ मिल करके एक आध हमारे पास फार्माकोलॉजी का और पैनल ले लें या डॉक्टर्स ले लें, सिर्फ 4-5 लोगों का पैनल हो, क्वेश्चन पूछा जाए, उसको टू द पॉइंट जवाब देना है।
ठीक है
गोबर के
सर।
लेपन से क्या कोरोना ठीक होता है? नो मींस नो। तो
नो।
सिर्फ 2 पॉइंट में यस तो यस और नो तो नो। तो मैं समझता हूं कि लोगों के अंदर जो ढेर सारे भ्रम है वो कहीं ना कहीं टूटेंगे। सो थैंक यू वेरी मच। and we hope that कि within a fortnight 15 days के अंदर एक हम अच्छा सा आपकी तरफ से मेरी तरफ से एक अच्छा सा करके और एक पैनल रहे और ओपन टू ऑल, नॉट टू
Yes, sir.
फार्मा प्रोफेशन, ओपन टू ऑल सोसाइटी में
Wow.
रन करें
Sure,
कि भाई
sure,
साहब
sure, sure.
आप व्हाट्सएप ग्रुप वाले इसको देख लीजिए, सो दैट
Sure.
योर कंफ्यूजन इट विल बी द क्लियर. सो
Correct, sir.
थैंक यू वेरी मच, थैंक यू.
Thank you, sir. Definitely, I have many people because recently we have conducted in many colleges in South India. So I have that panel also, and people from industry also, people from who are actually working on the myths and facts of COVID. So we will call 2 3 people, and we can have this within fortnight. We can have it, sir. Definitely, I'll
ओके,
arrange the things. I will arrange the things for sure.
थैंक यू अजीत जी, थैंक यू वेरी
Yes.
मच.
Thank
Thank
you,
you very
Ajit
much.
sir, for
Thank you very
joining
much,
and
sir. Okay.
increasing,
Yes.
and to
Definitely, sir.
Professor Gupta sir also for his continuous presence. I'm watching since last 2.5 hours. Sir is with us,
नहीं, मैं
and
आपको बताऊं,
it
मैं 25-30 मिनट मैंने बड़ा मतलब फुल्ली सुना, बीच में थोड़ा सा स्किप हुआ, बट बीच बीच में जो आपकी स्लाइड चलती थी या मुझे लगता था तो मैं उसको देखता था बराबर.
Fine,
was one of the
definitely. I hope
good.
that I met your expectations. That is the best reward for me, sir.
थैंक यू, थैंक
Yeah,
यू.
yeah. So thank you so
चलिए
much, Ajit
चलिए.
sir, for joining
Thank you,
and
sir.
hoping more
Thank you, sir.
sessions in the future as well. And I would like to thanks all the virtual audience participants on our YouTube channel also for watching this session. Thank you
Yes,
all.
sir.
Thank you so much. Thank you, sir.
Thank you so much, sir. Thank you very much.